So I am Cecilia Oregón. I'm the Executive Director of the Institute for Health Policy. And at the Institute, we host events and publish information to shape policy and practice on important health topics. We convene experts to share knowledge, spark discourse, advance collective thinking, and explore opportunities to cultivate healthy communities and promote more accessible, high-quality care. This is our first in-person meeting since the pandemic, and we're really excited to be here today and to learn a lot about the topic at hand and mental health quality in the workforce from all of you and from our esteemed panelists. So before we get started, though, I do want to go over some housekeeping. So I want to point out that there are staff working the event today, and the staff are wearing green name badges, or they have a ribbon that's green, so you can ask any of them any questions if you need any help with anything today. So we are recording this event, so I'd ask that you please silence your cell phones. Wi-Fi access, for Wi-Fi access, you would connect to the KP Guest Network and accept the Terms and Conditions button on your browser. All of the information that you need to know about today's events, including the agenda, the speaker bios, code of conduct, COVID attestation information, as well as relevant Institute for Health Policy resources, are available using the QR code that you either received at check-in or that are on your desk. And then I also want to point out that through the QR code, there's also a link to an end of the event survey, and we'd love to hear from you. We definitely use the information that is provided at the end of these types of events, so we encourage you to provide us feedback. Restrooms are located behind the screen wall, down the hall, and to the left, and we encourage you to take breaks as you need them. There's also a mother's room that one of our staff would be able to connect you to if you require it. If for some reason we have to evacuate today, please note where the exits are. There's one, the main exit would be right behind you where you entered the building. And if you have to take a call, again, because the event is being recorded, we ask that you please do so outside, or ask one of the staff members for help finding a room and a quiet space to take your call. Throughout the day, there's going to be opportunities for questions and answers, and so, and then we have also received a number of questions in the registration process that we've tried to incorporate throughout the day already. But during the Q&A, we will have a microphone available, and Nani on our staff will be walking around with the microphone in order to help facilitate that process. Lastly, if you are interested in using social media to communicate information about the event, we encourage you to do so. Please use the hashtag KPIHP. And lunch, importantly, will be served at 12. So to get us started, I wanted to do a little poll of who's in the room. So let me ask if you would please raise your hand if you are either a policymaker or work for a policymaker or with a policymaker. Great, thanks. Advocates or folks that work with advocacy organizations. Great, thank you, welcome. Researchers or academics? Great, there's a couple, thank you. Providers or clinicians? Wonderful, welcome. Folks from Kaiser Permanente? Thank you. And anyone I missed? All right, well, thank you. And then I guess another question is, how many of you have attended one of our IHP forums in the past? Great, thanks, welcome back. And now that we have those items out of the way, I'm going to transition us to the official start of the program with, so I'm happy to introduce Tony Baratta. Tony is Senior Vice President of Government Relations for Kaiser Foundation Health Plan and Hospitals. In this role, he oversees Kaiser Permanente's legislative and regulatory policy efforts. He leads a team of legislative advocates and policy professionals across the organization. He directs development of our public policy positions to ensure KP maintains a common voice in support of the organization, its members, and the communities that we serve. He is the immediate past board chair for the Public Health Institute. He's a member of the board of directors of the Alliance for Community Health Plans and the California Latino Economic Institute. He serves on the statewide leadership council for the Public Policy Institute of California. And I do know that all of these issues that we'll be discussing today are really important to him. So, Tony?
Thank you, Ceci. Great, thanks, Ceci. And I really do want to add my welcome to everyone. This series of forums that we have been doing for the last 6 or 7 or 8 years was really a brainchild of our entire team in government relations and public policy at Kaiser Permanente, where we've had an interest. Many of us are in the work of doing the day-to-day advocacy on behalf of the organization, working on issues that arise. And one of the benefits of working for an organization like Kaiser Permanente is that we have the opportunity to think longer term, to think more upstream, and that's a result of the nature of our organization, which is one in which we are both in the payer space, in the provider space. We're kind of in a unique role where we see that we're able to step back and, as a nonprofit organization, take the long term. One of the things that's always remarkable to me about our organization is the fact that we have an extraordinarily long tenure of enrollment of our members. People who come to, there are a lot of people who have no idea about Kaiser Permanente, but the people who do come to Kaiser Permanente tend to stay for a long time. I know, for example, in Northern California, the average tenure of enrollment for a Kaiser Permanente member is 14 years, which is really quite extraordinary. And because we offer coverage through the commercial market, through Medicaid, through Medicare, people can stay with us throughout the entire period of their lives and all of the experiences that they're having in their lives. So we tend to take a long view on many issues. And today's conversation is the 6th in a series of these forums that has been about mental health and wellness. So we put this effort into longer range healthcare policy, and the focus on mental health is really a reflection of the organization's concern and interest in the subject, and frankly, some of us who have a very strong interest in this based on our own life experiences and reflecting the fact that all of us in our society, in all of our families, are touched by issues of mental health and wellness. So it's really critical, and I will be the first to acknowledge that in many respects, mental health has taken a back seat to other types of healthcare issues in the policy space. And so it's been very critical. What we're hoping by bringing people together we don't always talk to talk about these issues is that we can enrich the conversations that are going on. I know that in the mental health policy space, in the advocacy space, we spend a vast amount of time dealing with the questions of mental health parity that has been the framework for much of mental health care policy for the last 30 or 40 years, including, of course, the recent regulations that were issued. And rather than getting into the ticky-tacky details of why pieces of this are workable or unworkable or problematic or make sense, I think that stepping back and looking at the overarching set of issues that are faced by the mental health community and in mental health policy really do get to some of the issues that we talk about in health policy all the time. Foremost for me among these is the issue of workforce and whether there's actually an adequate workforce to address the mental health needs of society in general. Is it adequate in total? I think most of us would agree it's generally maldistributed geographically, and certainly in terms of its diversity, the workforce is not really reflective of the broader diversity in our society. And so these are issues, and there are policy issues underneath all of these things, and our intention in this series has been in that space to think about, okay, can we work together, can we think with others about developing more creative solutions to some of the problems that we're facing? I could say the same thing in the area of quality. Mental health quality is an issue that is, there's many people doing incredible work in the space of improving the quality of the mental health and wellness services that are provided. Those are not always that visible to policymakers, and the policy solutions in that space are not immediately obvious. And that is a critical aspect that requires more dialogue and bringing people together. And that's one of the reasons that we really want to bring everybody together here today. We've seen it. I think everybody here, you're all here because you care about this. I could recite the facts about 1 in 5 adults in our society living with a mental illness or condition, the rates of youth psychological distress in the wake of the, can I call it a recently concluded pandemic? I don't know if I can say that. But we know that coming out of that extraordinary time in our society, things have changed and needs have changed. And there's a much more intense need for psychological support and different approaches to helping people get through what's going on. So at Kaiser Permanente, let me say one other thing at the outset. At Kaiser Permanente, we have an extraordinary team of people who are working on mental health services every day, figuring out how to do a better job of providing access, improving the care that's there. We have had our challenges over the last few years, which many people have heard about and are aware of. And a piece of that is because of the nature of our organization. What happens inside our organization is much more apparent and much more visible than it is in the diffused, networked kind of society that most of the health system operates in. So we're aware of issues that we have. We have a tremendous desire to address those issues, and we're really committed. Our commitment here and to continue talking about health policy in that space relates to that as well. I want to highlight a couple of things that I just think are amazing programs that we have at Kaiser Permanente. One of my favorite things ever created in our organization in the 30 years I've been there has been the Mental Health Scholars Academy that is in place and is training Kaiser Permanente employees in other fields who are interested in transitioning into mental health services. We have a couple of colleagues among our team and adjacent teams who are going into this program because they care so much about this, they feel called to it, and we're making it possible through this program that they can continue in their current jobs, they can get the training, and when it's the right time, they can transition into getting the hours they need around their schedule in order to get fully trained and then transition into the mental health workforce. And I can tell you, if people like this are the ones who are coming in to the mental health field, I am vastly more optimistic about what our future looks like. These are amazing people who care extraordinarily coming into this field. In that program, 2/3 of the students, the employees and students, are people of color, which is remarkable. One of the biggest problems we have is the lack of diversity in the mental health workforce. I think it's about half are bilingual. Addressing, and this is a tiny little piece of addressing what is a critical question about whether there's enough linguistic capacity to deal with people of all backgrounds in the mental health space. We're also addressing the mental health professional shortages in our communities and increasing the number of professionals in the field by creating and funding a mental health workforce accelerator program. That program is to provide information, resources, and training to develop skills, helping protect physical, emotional, mental health through adversity, trauma, and other distress. So these are amazing programs, and while we are a large organization, we cannot do this at scale and solve the entire problem. We want to share what we're learning, but even more important, we know we don't have all the answers. We want to learn from everybody else and see how we can involve the lessons that others are learning into the programs that we're developing. So we've got questions. Very interested in hearing. One of the things I love about having these meetings and coming together is hearing the questions that everybody else has of us, because that really informs how we need to be, what other directions do we need to do to break down our own internal thinking. When we get convinced of the way we think about things, I think we know that's not the best thing. We really need to have constant pressure pushing on what we think we know, and the only way we can do that is by learning from listening to other folks. In my role in government relations, I'm constantly thinking about where can we address this in policy, and I'm very interested in hearing your ideas around that, and as is the entire team. So with that, let me introduce our keynote speaker, Teresa Win. Teresa's Mental Health America's Chief Research Officer. She leads the organization's Center for Research and Innovation. In that role, she works to improve access to mental health care through data and digital-based innovations. Areas of interest include prevention, early intervention, education, and building a full recovery-oriented mental health system of care. This is actually an area I'm very curious to hear about. Prior to my work at the Public Health Institute, I sat for 9 years on an organization's board, the East Bay Agency for Children, which is like right in this space, providing lots of these types of services in Alameda County and getting to see the gaps, the opportunities. There's tons of policy opportunities in this space, so I'm really curious to hear more about that. Teresa's a licensed clinical social worker with 20 years of experience in mental health as a clinician, educator, and advocate, focused on children and adults with serious mental illness, people experiencing homelessness, dual diagnosis treatment, and early intervention of psychosis. As an advocate, she works to build consumer-based mental health workforce, improve access to treatment through community-based and recovery-oriented mental health programs, and address the needs of underserved communities. This list goes on. It's really quite remarkable. So I could continue, but involved in U.S. Olympic and Paralympic Committee Mental Health Task Force, which is fantastic, Mental Health Research Network Advisory Committee, and PCORI. And PCORI is an area where there's a lot of great policy that goes on. So I'm very glad that she's involved there. So let me invite Teresa up to the stage. Thank you. I hope I didn't do too much.
Oh, God, I'm so sorry.
All right.
Hi, everybody. Can you hear me with the mic? Hi, Karen. So I'm here to talk about the future. Let me see. The future. Certainly in human history, we have faced changes, industrialization, technology, that for the people who lived in that time, the future seemed insane, impossible, untethered from reality. And I think today, our generations that live now are facing a similar kind of fear and awe about the changes that are happening, right? Can you think of some that bring you fear and awe? Somebody answer. The audience feels far, and that makes me feel anxious. Yes. Climate change. Our earth is literally burning. And what does that mean for your home to not feel secure? Anybody else? I can think of at least two that, yeah. Yes, AI and aliens. It's like, which of the overlords are going to come, right, and take over? Which of these changes is going to happen first? So, but there's also something very interesting about this change, because I think in human history, we also, in living through this time, have the opportunity for our history, our epigenetics, to train us in our blood, in our bones, and in our minds, to reinforce the skills and the knowledge that helps us survive the horror and root ourselves in the hope to survive this change. And thinking about the future is something really hard for me. When I was 8, I found myself sitting in front of a bathroom. Like, why I am in front of a bathroom, I do not know. But what I was certain at that time was I was going to die. That is what it felt like. My heart was beating in a way that I could not understand. I could not breathe, choking on my own breath at 8 years old. And the walls in the room was simultaneously large and small, all at the same time. And I remember looking at the floor and thinking, what? This is what it feels like to die. You know, and it was now looking back and as an adult, realizing that this was my first experience of knowing what it felt like for my brain to convince my body to do the impossible. And then 11, not that much further along, I'm sitting in the kitchen. Again, I don't really know why I'm picking these strange spaces in my house, you know, where I lived. And I thought, hey, I've been thinking about death all this time. for the first time in my life, I think I know a way. I finally have the fortitude and the means to execute what I wanted. And I wasn't scared. That's what's weird about that, you know, and it still freaks me out. It doesn't feel scary. Death was an invitation. It felt like peace. And that's depression. It's absolutely wild. And I chose to live that day because my nephew, only 3 years younger than I at that point, only person in the house. Why were we alone? I have no idea. He just starting his own mental health journey, looking at me and was like, chose to stay alive for him. So the future feels tenuous to me. You know, weird that y'all would invite me to come speak about the future. Because forever it felt like far away. I didn't have the benefit of thinking about the future, but as I got older and I learned to live and chose every day to live, choose every day, wake up and choose to live, that I feel grateful that one of the benefits is that if I allow myself to stay in the adventure of life and allow myself to get to focus deeply on this, on the awe, that what I found is that one of my deepest values in my life, we went through an exercise at Mental Health America about values. I realized that one of my deepest values is curiosity. Because curiosity saves me. It allows me to ask questions about where I come from and why I have the brain that I have and why my family chooses to make the choices it does, and asks me to think about humanity and the choices we make and to have empathy in understanding suffering, right? And so, as with most people with disability, you know, I realize that I follow this path, and in my work, you do what you know, and I know mental health, and I know mental illness. So if I didn't do this, I only recently was like, I think I would have been like a physicist or something cool, but instead I'm here, and we're gonna make the most of it. And what I wanna do with you today is bring you on my journey of curiosity. What I get to do at my work, because I found my home, I found my people at MHA who value lived experience, and what that means to say, okay, let's take this journey in a world where we don't know anything, y'all. You think we know anything about mental health and mental illness. We don't know anything. And that's kind of a cool spot, you know? So I'm gonna take you on this journey of what we've been curious about and what we've been exploring and the questions that we ask. So there's a lot of things here. And I'm trying to infuse, you know, something interesting in all of these things that sometimes can feel very wonky. So are we ready? Are we cool? All right. So data. I'm in research, which is funny because I am not, like, I don't have a PhD. I'm a social worker. I'm a consumer. I love that MHA lets me do this. We have research reports that look at our traditional sources of data. You know, Keris Myrick sitting here speaking today was asking me about, like, how do I understand workforce shortage? The government has put out surveys. County mental health systems have tried to answer this question about data and try to help our policies develop from these systems, these traditional sources of data. But when I think about change, and I think about the future, and I think about innovation, I think about where we have data that we're not using. Right? So MHA collects data online, and this was entirely by accident. I'm going to show you some of the data that we have. But I remember sitting in a meeting, and we were asking about prevention and early intervention. And we spend so much time looking at healthcare data. But if I look at healthcare data, is healthcare data prevention? The answer is no. It's not, right? It's not. It's like, I don't know how long it takes you to get into your system. Even as somebody who's really adept at getting into my system, it still takes me months. And then forget it. Like, if I'm in an episode and I haven't connected with my therapist, my brain is basically telling me, forget it. Just don't even bother, right? But I remember the first thing you do when you know you need help, what do? You go on the internet. You go on the internet. At best, sometimes I'm looking at my provider's website, and I'm trying to answer the question, like, how do I get in this system? So if a system wants to identify how long it takes for somebody to go from when they first ask these questions to when they can finally get into the system, I'm not looking at healthcare data to answer that question. And it sometimes is still surprising that we aren't thinking about these things, using the data that are available to us to be innovative, to solve these questions, and we're still using enormously old data to say, like, this is the duration of untreated mental health, when I look at online data, I'm like, what is the duration of optimal engagement? What is the timeline, the window of optimal engagement? And so we have tools on our website at MHA, and I'm going to go through this really fast because these aren't important, but they are resources that I'm happy to share. But MHA, Mental Health America, has been fighting for ubiquitous mental health screens forever, 100 years, in fact, since 1909. We have documentation about how even then we were like, can you just screen, ask the questions? So we threw some stuff on the internet back in 2019 and found that many people, mostly youth, come onto the internet because they, like you, when they first struggle with a mental illness, Google. I wish I had Google to say, am I stressed or depressed? I want to die. How do I kill myself? These are the questions that children ask when they come to our site. They are scoring severe, moderate to severe on most of the conditions, or positive for the conditions. They have insight. They know something is wrong already, and they're coming and they're looking up, they're trying to take a test. 54% of them have never been in treatment before. Okay, so we have an opportunity to have the earliest intervention. Suicidal thoughts among youth are the highest. You have heard this stat over and over again. Our future is bleak. We have the technology, the AI, the insecurity, workforce development. We're talking about, well, what does that even look like in the future when the earth is burning down? I think our youth have some insight into this, but the numbers, I think, are very interesting, that even by 8 and 10 years old, 2,000 of them, very small percentage of our overall screeners, are struggling with the highest thoughts of death and suicide, but that stays through your teens. And I don't know how many of us are thinking about workforce development from a youth perspective, and that's the biggest thing I kind of want to impart right now. Our data has been cool because it allows us to map need at a county level in real time. MHA has been committed to putting out our data on a quarterly at best, or every 6 months real-time data from 2023. All the federal data I find is 2 years behind. So if we want to be innovative, how are we using data? How are we sharing data, collaborating on data to make effective change? Our future workforce. I showed you the youth in despair, and I talk about what it feels like to be a child wrestling with these hard topics, because I think that's the reality, is that many of us know that these issues happen at a younger age, but we don't have the power to do anything about it until we're in our 20s. When I go to college and I have insurance, maybe of my own for the first time. These stats, we've been looking at addiction at MHA, and these stats are just a reminder, again, of even for the most profound issues, like how I'm going to use substances to cope with my mental health challenges, are screaming there. I mean, I think the opioid epidemic is a clear indicator of the distress and despair that is happening in the country. But here, I think, for MHA, what's important is the age. The age, that even 50% of our youth and our population, the representation of age here is about 50% are under 25 years old, struggling with more than one substance, more likely than not. And I remember the first time I did drugs, I was about 8 or 9 years old, and I found cigarettes. And I'm like, okay, as an adult, that now makes sense. My brain was like, sweet, this wakes me up. But did not have, I think about this all the time, just like, what does that mean to have a workforce that is prepared and trained to do the right thing in prevention and to handle despair? So if we think about the future, we also have to think enormously about despair, because we talked about the change, and we talked about that I could sit in fear and I can sit in horror. And this is what our children are sitting in. They have so much insight. These are their words. We ask them to just fill in the blank about what's going on for them, what is their concern. And there's so much insight here. My brain wants to kill me. How many times have I thought this actual question? That to struggle with a mental illness means my brain is literally trying to kill me, convince me that that's the right thing to do. And so at MHA, we very much care about peers. And I think increasingly we're moving to youth peers. Because I worked in workforce development for a period, and I don't know about you, but when I was young and somebody said, what do you want to do? I had no idea how is one supposed to know, especially when you don't even have access to what is a job? I was like, what have I seen people do? Or what does my parents tell me that I should do? But I did not have access to the breadth of opportunity in workforce. And so a big part of my work at MHA in the past at some of our affiliates was to start getting as young as high school age, to teach them about what mental health is, but also teach them about what it looks like to be a mental health provider, which most of them didn't even think about. And so as early as high school, youth who are wrestling with their mental health problems learn the skills to support one another, and infused that early, converted even, to what it means to turn your suffering into power and to support other people. And that is so cool, because the youth that I work with then are now social workers, psychologists, researchers, doctors. They've been inspired, and that's the way. That's what innovation in workforce looks like. Not looking at curriculum or yes, do that, but what can innovation look like? How do we get in those communities and start from the very beginning? And I'm going to end with technology, because I don't know. This ties in future, and I think that it makes me anxious. A couple things. At MHA, we have a new tool called Changing Thoughts with an AI Assistant. And I don't know if you'll be able to see this, because I'm going to kind of walk through. A person submits. This is basically transitioning cognitive behavioral therapy and cognitive restructuring, and then using artificial intelligence into the AI helps them categorize their negative thinking into specific thinking traps. Then they have to pick the thinking trap, and then we've tested, like, if the AI tells you your thinking trap, which ones do you pick versus when you organically have to decide yourself, which is sometimes what therapy looks like. And then you have to work on reframing your thought, and then you pick the reframed thought. And the AI generates this reframed thought. And we are teaching this AI to engage in human empathy, which is not, I think what most AI that started was not inclined towards that, which is a whole nother topic. And then can you work with what the machine gave you to continue to reformulate your thought? Okay. So let me go back actually on this, because I am going to finish. I don't know, technology in the future. Sometimes I'm actually freaked out that MHA and our small little company has access to this. And what it means when technology trickles down. And the fact that I could even work on a project like this is really interesting and telling, because I know that the machine that I work with, which was GPT-3 and now 4, we're thinking of transitioning there, pales in comparison to the intelligence that's being trained at technology companies, right? And the discourse that's happening around the country about when we're going to advance in technology so fast that technology itself will think and create and breed, and will no longer need human intervention to make decisions, but that we as humans will rely on technology to make decisions. And that reality is coming sooner than later, like 15 years, and I can't even be dead. I'm going to see that reality. So if I let myself sit in fear, then it's just so overwhelming, and I'm so overwhelmed for fear for myself and children and the future. And then I take a breath and I try to sit in adventure and sit in awe. But then I think that there's a responsibility for us as mental health professionals, maybe even, to speak up about new intelligence and to say, we have been through suffering. And if you train a machine to only think about these subsets of humanity, that's dangerous. Are we inviting enough people to be in this work that also trains the machine to sit with empathy and human suffering and the beautiful sides of human brains? Because otherwise I'm a little afraid that we're bent on destruction and our values are misaligned with what would be required for us to survive and to succeed. And so I'm so glad I have all of you to help me figure this out, because everybody I've met in mental health is just really beautiful and wonderful. And I think it's because we do have the privilege of saying that we sit in this space where mental health is so exploratory and there's unknown opportunity to explore. So thank you.
So Teresa and I are going to have a little bit of a conversation, but first I really want to thank you for sharing so much. Teresa and I have had the chance to work together on a previous project, but I appreciate your story being added here today. Thank you for that. You've given us a lot to think about, and I know AI is on everybody's mind, or 99% of people might be thinking about it, and I know we at Kaiser Permanente certainly are. So I really appreciate that you brought that to the table. But I do want to maybe go big picture here, and if we think about mental health quality and the workforce, and I think your presentation hits on a number of components there. What do you wish policymakers really understood about this?
About AI or about workforce?
Let's take workforce and quality.
How many times do you have to scream about money? And investment. So leadership is charged with making decisions about how money is spent. So if I think about what I wish most, I wish that we all could ensure that we were prioritizing funding where it mattered most. How much does a family invest in a security system versus how much a family invests in food, in exercise, in healthcare, in bicycles, in all the things that bring health? And so investment, because I don't know, y'all, we are constantly crying and screaming and asking for more budget, more money, and it pales in comparison to some of the spaces that money is being spent. And you ask yourself about where our priorities are, how fear and inspiration or awe is driving our priorities.
Yeah.
So.
Yeah. So I also, while I'm asking Teresa some questions, I would encourage questions from the audience as well. We have Nani on our team will be walking around with a mic if there are questions. So I guess, there's a lot that you shared that makes you anxious about the time that we're in. Is there anything that brings hope for you?
Oh, the youth, you all? Our children are so fierce and scary. But I mean, they're kind of inspirational, and they have technology and power and knowledge to make change. And if we could embrace that, I've seen how maybe they can help us move along in ways that we couldn't before. If we could also not lean into some kind of generational divide. Because they're going to be the ones that have been living in the world that we didn't, and so they'll be able to consume and understand technology in ways that we couldn't either. And so I think that survival will also depend on our ability to hear and listen and grow rapidly, and we're going to do that better if we have an intergenerational approach to change. And that's something that I don't think has happened as fast as it's going to, and that's also going to be, I think, hopefully exciting to watch. But youth are creating. We have more youth at the table at MHA than ever before, and they have pushed us to ask questions about hope. Thinking about radical hope. So some of the dialogue at MHA is not about symptoms and depression and like these old clinical things. They're like, no. Let's talk about social media and radical hope. And I'm like, what? That's okay. Let's talk about it.
Yeah. And can you describe what radical hope really is for folks that you're talking to, for the youth that you're talking to?
They just gave us a 2-hour lecture on radical hope because I think that they have to wrestle with radical hope because their peers, teenagers, youth in college have faced a kind of real existential crisis we didn't. And they're really using the internet to try and pull anything that could mean. And they're wrestling with it from a philosophical, in the way that I describe, but it took me to my 40s to be able to describe and say, I feel hope and despair. I feel despair and fear. And I could sit in this fear and despair, or I can think about hope. I learned not to talk just about like my PHQ-9 score or whatever it is, but okay, so where do I go to look for hope? And also learning how to control your technology and the way that it influences your brain. They're so much more adept at this, at understanding how to. We're sitting in like trying to decide what amount of time or when do we expose our children to technology, and they're already at how do I use technology, how do I set limits, how do I use the technology to set limits and understand myself and find meaning and find hope. And so I can already tell that they are way ahead of us in processing the meaning for this kind of work.
That's great. That gives me hope as well.
Yeah.
Let me see if there's any questions out there. Yes, great.
Thank you so much for all that you're doing. I'm wondering about schools. How can we use schools to make a difference? The schools are crushed in terms of their funding, but is there anything that we can be doing to really use schools? I hear all the time, you have an elementary school with 300 students and one counselor.
Yeah.
You have one psychologist for multiple schools. So what can we do in schools, both in terms of early prevention, but also in terms of early detection and movement into treatment?
Yeah. We have been pushing a lot for just mental health education in schools, because if you think about health class, I learned about my period. I mean, we've learned the basics.
Yeah.
But humanity has been afraid to talk about the brain, probably because we don't know much about it. But there's some progress happening at state levels across the country to reinfuse mental health education as part of health education. I think that's the bare minimum. And that also allows schools to infuse that into curriculum, which is a real barrier for schools. Like, you can't just add things on top of what schools are expected to do when they raise our children all day. Mm-hmm. I think what's also cool is thinking about after school. Sometimes these are the places that the most needy youth and children are there, because their parents can't pick them up at 2. Certainly my parents couldn't pick me up at 2 o'clock. So I went to, the YMCA comes in, or some program comes in and provides out of school activities with the school invest in that space. That's a really interesting opportunity to use. So at MHA, we're kind of exploring what investment in these school adjacent systems could look like to kind of wrap around an environment. And then I talked about workforce. So I want to take away, like, let's start just thinking about not just curriculum, but let's go into the schools. Let's get youth energized to, again, turn their suffering into action and start doing that conversion early, because I think that, you know, when I worked with youth with psychosis, by the 10th grade, many of my kids were dropping out of school. When I was doing workforce development, we were starting at high school. I'm like, what would it look like if I could start at middle school? But also, like, did anybody love middle school? It sucks, right? Middle school is torturous and like just so rife with bullying. And so how do we think innovatively about these critical lifespan development periods, and then invest in innovative ways that allow schools to get around some of their barriers? Like, what does workforce development in middle school look like? Nobody's ever done that. I think that would be a really interesting space to grow.
I also know that for Kaiser Permanente, we do work in schools as well through our Thriving Schools program. And one area of focus, though, has been on teachers and teacher mental health, because they're in need, they're stressed, they're working with children that are in need and stressed, and so supporting the teachers and faculty is also something really critically important.
We're losing teachers faster than we can keep them.
Yes,
Yeah.
yes. Other questions? Great.
Hi, I'm Lee Wilson Hall from the Camden Coalition in South Jersey. Thank you for your remarks. Thank you for also sharing your personal experience. It's not easy to do in front of a group of people you don't know. It just sets such a nice foundation, I think, for the day. My question is about I really appreciated your remarks about measuring access to mental health, and what you were saying about how do we identify when someone actually says, I want to access an appointment or healthcare, the time between that and when they're actually able to connect. A lot of the work we do is working with partners to look at improving access, but then at the end of the day, a lot of the data we have access to is the end result, is whether they actually made the appointment. And we can see the no-show rate, the gap between identified mental health need and treated need, but we have a lot of difficulty really getting access to the data that measures what happens in between. And I think we end up relying a lot on qualitative data, which is so important. But just curious how you and MHA are thinking about that, and if you have any guidance around data sources.
Yeah. Except to flag that people have data that they're not thinking about how to use innovatively, I haven't figured out how to get them to commit to also pulling that data, because it's there. That's the thing, right? And I think we get so accustomed in our ways to look at the data that we're used to looking at. And that's coming in at an enormous rate. And that's why using healthcare data is so where we've gone. Mm-hmm. But if we want to think innovatively, we have to build out our workforce and our data scientists and our systems to be able to say, well, you know what, can I get your website data?
Yeah.
Can I get the data from how many people called or just opened up that browser? Most people aren't calling, but on, your browser data, just, hey, could you, people also have to log in sometimes, so can I look at the login? What was the time period between when they logged in and tried to look for that resource and when they landed in your ER? Mm. And if you're looking to save money, then you're gonna try to be strategic about what we've been calling the window of optimal engagement. Because I think that window happens way faster than we think, and if you're really trying to save money, then you're using all the resources you have to move investment from just looking at ER data and healthcare data and trying to be innovative about the other non-traditional sources of data that allow you to peek into what's happening in those earliest stages. So that's what our screening program has, I only started thinking about this because of the accident that happened as we think about screening, but we did a research project with Microsoft Bing, just looking at how many people start searching for depression tests and I want to die, and then who's transitioning to what they're searching right afterwards. And we found that even for people who were scoring mild in anxiety, for example, that within 40 days, they were searching active suicidal thoughts. And I was like, what does that mean if my old assumptions that I had 10 years for some vague sense of a duration of untreated mental illness, but in today's reality and our data that we have access to, 40-day window, you know? But I don't also think that those youth have, they might not be getting into systems.
Right.
How long do they exist in suffering before they actually access health care? If we're truthful about trying to prevent suicide, are we going to ask these hard questions and respond to what the data are telling us? Or is it just too much? And we just don't have the political and the public will to do something about it? I don't know. Yeah, it's there. And we'll use it.
Yeah, thank you for that question. And we are unfortunately out of time, Teresa. So I do want to thank you, though, again, for your story and for connecting the dots between your experience, the work you're doing, and sort of what you're hearing and learning along the way. So thank you so much for that. So now I think we're going to move to our next session. So thanks, Teresa. Thank you. So now I'm delighted to welcome our first panel to the stage, and they'll be focused on mental health access and quality, and they'll be moderated by our KP leader, Dr. Andrew Bindman. Dr. Bindman is Executive Vice President and Chief Medical Officer for Kaiser Permanente. He's responsible for driving superior quality and equitable health outcomes through the integration of quality, innovation, care delivery, and research in collaboration with the Permanente medical groups. Prior to joining Kaiser Permanente, he spent more than 30 years on the faculty at UCSF, where he practiced and taught internal medicine while conducting research on health access and outcomes. He was elected to the National Academy of Medicine in 2015 and to the Association of American Physicians in 2021. So with that, let me go ahead and hand it over to Dr. Bindman. Thank you. Okay. Thank you. Go ahead.
I was told I'm supposed to sit in the middle. Are we in a certain order?
Wherever you're comfortable.
Oh, maybe
Well,
we should all.
thank you for the lovely introduction, and good morning, everyone. It's great to see you, and thank you for the opportunity to be here to be able to moderate what I think is going to be a lively panel. I'm joined this morning by three really distinguished guests and really treasured colleagues that I've known for many years. I'm going to introduce them and then maybe say a few comments to kind of set the scene for the discussion that follows. So let me first introduce my panelists. To my immediate left is Dr. Harold Pincus, who is a professor of psychiatry and healthcare management and policy. He co-directs the Irving Institute for Clinical and Translational Research at Columbia University and the New York State Psychiatric Institute. In addition, he's a co-chair of the National Quality Forum Standing Committee on Behavioral Health and the World Health Organization ICD-11 Committee on Quality and Patient Safety. He's held a number of previous roles at RAND, Pittsburgh Health Institute, and most notably was involved at the American Psychiatric Association, where he founded the Office of Research at the National Institute of Mental Health, and he's also served as a White House and congressional staff through that office as well. So he's also, I just want to say, practicing. So for 22 years, he worked an evening a week in a public mental health clinic caring for patients with severe mental illness. So has tremendous policy experience, academic background, and patient care experience. To Harold's immediate left is Dr. Dora Hughes, who's currently the acting chief medical officer and acting director of the Center for Clinical Standards and Quality for the Centers for Medicare and Medicaid Services. That office, sometimes known by others as CCSQ. Then that center executes on a national quality, clinical quality and safety standards for healthcare facilities and providers, and establishes coverage determinations for Medicare beneficiaries. Dora previously served as the Chief Medical Officer at the CMS Innovation Center, as the Counselor for Science and Public Health at the Department of Health and Human Services, and an Associate Research Professor at the School of Public Health at George Washington University, and had previous roles at the Commonwealth Fund, and really has a long and distinguished career in the area of quality measurement. And then next to Dr. Hughes is Dr. Sherry Glied, who is the Dean of the New York University's Robert F. Wagner Graduate School of Public Service. Previously, Dr. Glied was a professor of health policy and management at Columbia's Mailman School of Public Health and the chair of the Department of Health Policy and Management. I had the pleasure of working with Dr. Glied when she was the Assistant Secretary for Planning and Evaluation in the Department of Health and Human Services. She's also been a senior economist for healthcare and labor market policy on the President's Council on Economic Advisors under both Presidents Bush and Clinton. And her areas of expertise are in health policy reform and mental health care policy. So you can see from those very distinguished bios from our speakers that we've got some real experts here in the room to hear from, and I'm very much looking forward to their comments. But before we get to them, let me just say a couple of things about what to maybe listen for in their comments. I think we're going to talk a little bit today about the role of healthcare measurement as a way of driving improvement in mental health and wellness care. And here's how I would sort of describe, in my own words, the state of healthcare measurement today. Healthcare measurement evolved in many ways out of the work that happened at what at the time was the Institute of Medicine, now the National Academy of Medicine, when it set 6 dimensions of what quality of care is all about. And I think all of you know these probably quite well. It's effectiveness, efficiency, timely care, patient-centered care, safe care, and care that is equitable for all. Well, the good news is that since setting that set of dimensions of what makes quality of care, we've embarked on a journey to try to figure out how to measure quality of care. And the good news is that we've formed some consensus around measurement in different aspects of care, including mental health and wellness to some degree. But I guess the bad news from my point of view, and something that I think we'll probe today, is that a lot of that consensus has formed around measures that aren't entirely getting at what many people in the public and what many providers would identify as truly at the heart of what matters the most. And what matters the most for many people are the outcomes of care. Where we spend a lot of our time measuring are the processes, the things that we're doing, as opposed to what we're achieving. And this has particularly been a vexing issue, I think, for mental health and wellness care, where there have been challenges identifying these kinds of measures. There's a real reason why not only the outcomes most important and meaningful, but I think without measuring outcomes, we're also really struggling with our ability to achieve health equity. And that's in part, I think, because when we focus on processes and whether processes are equal, in fact, the Institute of Medicine had a report called focused on equal treatment. The problem with the focus on processes and whether care is just equal is that it doesn't attend to the fact that people start in different places. And so that just providing the same care to everyone isn't necessarily going to allow everyone to achieve optimal health and their best possible health outcomes. And so without focusing on outcomes, we don't take the whole person in mind and consider some of the other factors that contribute to what really matters to them most in terms of maximizing their health. And so without a focus, I believe, on outcomes, we can't achieve one of the important dimensions of quality, and that is equity. I think that when you have a system like we have at Kaiser Permanente, and as we're talking about more broadly today about moving toward value-based care, we start to have an alignment and an opportunity to perhaps bring those factors around social determinants and a focus on outcomes to create greater alignment to focus on that. And I think that is one of the things that I would hope our panelists might comment on today. Because when one is working in a value-based environment, the goal is to keep the population healthy rather than to treat them with lots of things when they're sick. And so by doing that, one is naturally attending to all the things that contribute to keeping people healthy, not only the things that one can do in the care delivery setting, but also how one can attend to some of the social determinants like food security, housing stability, transportation to be able to get to care, open space to be able to exercise, all the things that we know contribute to healthy living. And so these are things become very important and become more of a focus, I believe, in a value-based model, such as the one that we have at KP, but that is emerging and is being, I think we'll hear about from CMS, remains a focus of a lot of the work that they're doing. Now, I say all this, I've laid out sort of the hypothetical benefits, if you will, of shifting to a focus on outcomes and why it's more important for our patients, why I think many providers, in fact, think that that's what they're in the business of trying to attend to, and what I think ultimately is important for equity. But there are real challenges in being able to do this and to be able to measure it effectively, having to do with the way we capture data and the way we assemble data in our different environments of care. So recognizing the scale of this challenge, I am going to turn to our three panelists as true experts who've thought about these kinds of issues and to do a little bit of reality testing for me and for all of us today about what are the opportunities ahead for us as we try to shift toward value-based care, particularly with mental health and wellness in mind, and what are also going to be the barriers that we need to overcome to be able to truly provide care of the highest quality that meets all 6 dimensions of what the Institute of Medicine laid out, including equitable care for all. So with that, I'm going to turn it over now to our first speaker, Dr. Pincus. I think you'll be leading us off. Is that right? Yeah, sure. So please. Yeah, thank you.
Delighted to be here. I'm not sure how I advance the slides. Do I just say advance them? Oh. I see. Okay. So as I think about it, I agree with everything that Andy was talking about in terms of what we need to do and where we need to go. But we look at the challenges ahead, I think I group them into sort of 5 major categories. One has to do with access, actually people being able to receive care. And there's a lot of barriers that they face in trying to get that. And I think Teresa earlier had really alluded to some of those. Number 2, as Andy just said, there's the issue of equity. And there's all kinds of dimensions of equity. And one of the things that we sometimes forget about is equity across a disparities population that's part of the mental health field, which is people with severe mental illnesses who die 10 to 20 years earlier than the general population. Number 3 is quality, and I'm going to talk a little bit more about that, why I think that's in some ways an underlying issue in terms of the key areas that we need to address. But also another underlying issue is the fact that we have a tremendously fragmented kind of care system. I mean, if you think about it, in the start off of what Teresa was talking about from 1913, one of the key issues that were to be addressed by at that point, I can't remember what the name of it was, before there was a Mental Health America, was actually to try to integrate care from both general medical care and also mental health care. And we're nowhere close to doing that even today. In fact, it's gotten even more fragmented because most states have a separate substance abuse agency from a mental health agency. So things are really getting quite fragmented. And finally, I think the answer to each of those questions, 1 through 4, is issues around accountability. Accountability both in terms of being able to measure things so that people can not only be made accountable, but they can also improve the kind of care they're providing. Number two is to provide incentives to actually have it be meaningful to people, to actually make a difference in improving quality, either through providing incentives through value-based payment or by influencing regulations. And the recent change in the parity rules, or the proposed change in the parity rules, is one way of enforcing different kinds of changes to occur to make things work better. And there's several actions that can be taken. One is integrated care. There's been many, many attempts to integrate behavioral health care and general health care, going back literally centuries. And right now, we're not really enforcing that in a clear way. Going back to my point about sort of earlier about accountability, when I talk about accountability as a shared accountability, so to be sort of, to be more specific about that, if I'm a psychiatrist who's treating somebody with both schizophrenia or some other psychotic illness who also has diabetes, I should be accountable for both the outcomes for their mental health problems as well as for their outcomes for diabetes. As should my colleague, the diabetologist or endocrinologist or primary care provider. They should also be accountable for both the behavioral health aspects as well as the diabetes and other healthcare issues. If we're both accountable, that means we have to talk to each other. And that's exactly what I mean by shared accountability. And so that's why we need to get a more integrated approach. In terms of workforce, we clearly don't have enough people that are available to actually provide the care that's needed for our country. Right now, I run a national program on health and aging policy fellows, and we're focusing on aging in that. And each year, our country puts out 50 geriatric psychiatrists a year. We could quintuple that, and it would be decades, if not centuries, before we made a difference. We need to think about how we develop a workforce in a much more rapid way. And this means thinking about not just physicians and fully trained therapists and psychologists, but we're thinking about what really makes a difference in terms of what I might call the interstitial workforce. Because the biggest problem we have in behavioral health is that people fall through the cracks. How do we make sure that there's kind of a ruthless follow-up to make sure that people stay in care? And we don't need necessarily psychiatrists to do that. We need to have people that have been trained, peer support people, other kinds of people like that, to be able to engage people and keep them in care and to assess how they're doing. Right now, we don't really have that in place. We have a very, like a Tower of Babel almost, in terms of the different categories of different types of people in the workforce. We need to have a better typology that can be used. We need to have an ontology of the different tasks that people need to be trained on. And then we need to make investments and have leadership in certain areas, developing quality metrics. We really need to do more in the area of behavioral health informatics, including AI, but actually just collecting and maintaining the data so that it's accessible for improvement. We need to make up for the high-tech exclusion. The High-Tech Act gave resources to hospitals and physicians to obtain technology. Non-physicians and non-hospitals, like community mental health centers, we're not given those resources. We need to make up for that. We need to test new models and technologies. There are a lot are becoming available, but we need to do more in terms of actually assessing and evaluating how effective they are and how to implement them more effectively, and to provide technical assistance for doing that, and also to provide parity enforcement. Andy alluded to the Institute of Medicine and the Crossing the Quality Chasm report. There was a separate report following that in 2006 that I was a participant in. And it's remarkable when you look back at what our findings were and what the recommendations were, how much our findings still are the same, and how little has been done about the recommendations. So if you look, one of the things that was identified there is that We have a problem in terms of the nature of the behavioral health industry, so to speak. For a large portion of the behavioral health industry is a cottage industry of people working in individual practices with little infrastructure and with little connection to other parts of the healthcare system. It's still the same. Several years ago, we published a paper showing that 65% of psychiatrists don't take Medicaid. More than half don't take Medicare. Most of the cottage industry we're talking about is people who are professionals who do not take insurance at all and have essentially no accountability elements built into their practices. A large portion of what we're doing is now we're not actually doing measurement-based care. We're not actually seeing directly how patients are doing in a systematic way and making judgments about how to provide care based upon whether people are improving or not in a with systematic longitudinal assessment. We need to do more about establishing measurement-based care approaches. When you look at what the quality measures we have now, Andy alluded to the fact that there's a well-known Donabedian model for quality measurement of structure, process, and outcome. And really, a lot of what we focus on is primarily issues around process, as he noted. We have a limited investment, actually, in measure development that's been there over time, and we don't have great data sources. As I mentioned, the high-tech exclusion. We don't really have an ability to measure the content of psychosocial care. We simply know that a 45-minute visit was done. We don't know what the content of that was, whether it was evidence-based, whether it was simply chatting. For the most part, we've been looking at claims data as a way of establishing quality. And that's really like looking under the lamppost for your keys. The process measures are not really letting us know whether we have evidence-based treatments and whether measurement-based care is being provided. And when you look at a lot of the quality measures that we're using, not a lot of them are really associated independently with outcomes. So we really haven't made any progress on improving the quality of care. This is something from the latest National Healthcare Quality and Disparities Report. And basically, they called out behavioral health as being a particular problem in terms of the lack of improvement and, in fact, actually sort of lower rates of quality have happened over the recent years. And here's one example. This is actually not a great measure. It's a process measure looking at people who are discharged after a psychiatric hospitalization. And as you can see, over the past 15 years, there's been absolutely no improvement. In fact, it's actually gone down. And when you think about it, it's really hard to get somebody who's seriously mentally ill into a hospital nowadays. They have to be pretty sick. The average length of stay in a psychiatric unit is the same as for an MI, 5 to 7 days. And then people come out after that experience and have very little connection. More than half of them have very little connection with any kind of outpatient care. Talking about the movement to value-based care, several months ago I gave grand rounds for CMS, and this was the title of my talk. And if you look, out of those top 10 reasons, 2 through 7 are all about measurement and quality measurement. And so this is where we need to make the investment. So why don't I stop there and let Dora, you going to go next?
Yeah. Good morning. Thank you for inviting me here. I feel like that was a bit of a setup, and not in a positive way, for all the problems. And then it's like, okay, CMS, how are you going to fix all of this? But it is wonderful to be here and to share some of the work that we're doing in this space. It's also wonderful to connect with see some of my older colleagues here on the stage and in the audience. I also had a little bit of trepidation. I came in just as we were talking about radical hope, and I'm like, oh, our panel is focusing on quality measures, and it's quite a sharp departure potentially from radical hope. But we do have radical hope
in this space, I think, as many of you know, behavioral health care is a top priority for this administration, all the way to the top, with our president speaking often about the need to invest more in mental health care and really charging all of the agencies within HHS to think more about what it can do, what are the actions that we should be undertaking to improve behavioral health. As part of that, some of you may be aware that HHS has sponsored a number of internal-facing committees that are tackling some of the major challenges in this space, whether it's access to integrated care or suicide, opioid overdose, or thinking more about children. Across the whole gamut of issues, there are 6 different subcommittees, and a year later, we think that we've made meaningful progress across many of these areas. And I would have to say, certainly being at CMS, we are fully aligned, fully supportive of this administration's charge. We previously had a major initiative focusing on the opioid epidemic, and we have branched out to think more holistically about behavioral health care. Behavioral health care is one of our cross-cutting initiatives at CMS, meaning that is a top priority across all of the various centers, whether it's Medicare, Medicaid, CHIP, thinking about the marketplace plans, certainly for our center CCSQ. And so as part of that, it very much reflects the situation with our beneficiaries. 25% of Medicare beneficiaries, 1 in 4, have a behavioral health condition. 28% of our Medicaid beneficiaries have a behavioral health condition. And Medicaid CHIP is the nation's largest payer for behavioral health care services. So whether we think about the health toll for our beneficiaries, if we think about the financial toll for our health system, needless to say, behavioral health care has and will continue to be a top priority. A little over a year ago, we released our own 5-part plan, and access to high-quality care for behavioral health care services was one of those charges. We're also focusing on specifically more effective pain treatment and management. We're focusing on SUD. We're focusing on mental health care and data, amongst the other areas. But I think even a year later, we still have been able to report some impressive progress, and I'm going to share a few examples here today. I am going to start with access to workforce. Certainly, as the nation's largest payer, we have important policy levers at our disposal, and I think because we are in the thick of reviewing thousands and thousands of comments in response to our proposed 2024 physician fee schedule, I thought I would share some of the examples of how we're trying to address the behavioral health crisis in that role. In that role, for the first time, CMS has proposed to allow marriage and family therapists and mental health counselors to both enroll and to receive reimbursement through Medicare. And I think that gets to some of the point that Dr. Pincus was making. It doesn't always have to be a psychiatrist. It doesn't always have to be a physician. We really have to think about who are the other providers that can help to fill the gap in care. In addition to those proposals, we've also sought comment on increasing payment and coverage for intensive outpatient behavioral health services, crisis psychotherapy, other health behavior assessment intervention services by not only marriage and family therapists, mental health counselors, but also licensed clinical social workers. And there's been a whole other host of other flexibilities if we think about telehealth or audio. We think that through PFS, we've really signaled our commitment, again, to increase access, think about payment, consider workforce in the behavioral health care space. Beyond Medicare, as I mentioned, obviously Medicaid is a critical payer. And if we think about children, I also picking back on one of the questions from the former panels, how are we helping schools? And as one example that I could note is that we have announced that we intend to establish a school-based services technical assistance center to really help states who want to do more to provide behavioral health care in school settings. But even aside from this example, Medicaid is increasingly a focus across all of our efforts at the center, and I think some of the models at the CMS Innovation Center help to underscore that important point. As an example, one of our models, Integrated Care for Kids, is specifically focusing on how do we identify children on Medicaid under the age of 21 that have significant mental and physical health needs. and how can we help to connect them to care. And the second part, in addition to it being Medicaid, in addition to it being one of CMMI's few pediatric-focused models, it also picks up on another point that's been made by Dr. Bindman and Dr. Pincus, is that we have to think beyond the medical model. We have to think about how can we better integrate community health services, community health interventions into the clinical care. And as one of the key outcome measures that matter, is foster home placement for children in the INC model, in addition to some of the more traditional medically focused outcomes. And so we're pretty excited about that model. We have another model that's focusing on pregnant women with opioid use addiction. We've also signaled, I'm not trying to make news today, we've also signaled that we have another behavioral health model that's under development. I think that one too will address issues, again, with especially thinking about community-based providers, thinking very much about equity, and also integration. How can we do a better job integrating physical health services, clinical service into behavioral health settings and vice versa. So through the CMS Innovation Center, we're certainly trying to continue to think about how can we expand access, bring in more workforce, and focus on, again, the measures that matter. What are some of the outcome measures? That being said, and maybe I'll focus for my last couple of minutes on quality measurement. I will say, if you look at across our 102 behavioral health measures, we maintain a quality measure inventory, and we looked at how many behavioral health measures are actually in there. Many, if not most of them, are in fact process-based. For the reasons the science is not always advanced, so it's easier for claims, thinking about provider burden. But that is the issue certainly we're focusing on. We have already said that we're continuing to innovate in this space, and as one example, we introduced a new quality measure around patient engagement for inpatient psychiatric facilities, that it will be a patient experience measure. We think that that could help to provide important information across our providers. We have also proposed a new measure of the median time from arrival at emergency department to discharge across a number of the conditions, but including among those is the time to discharge a patient to an inpatient mental health facility. So in addition to our current measures, the measures that we're trying to develop, we are also very mindful that we have to harmonize our measures, align the measures across programs. We can't have just a set of measures for Medicare, a set of measures for Medicaid, a set of measures. How do we align across the programs and think of a core set of measures that could help us look at patterns, trends, identify disparities, reduce burden, and that we can also then maybe, ideally, align with commercial payers, and so it's across Medicare, Medicaid, and the commercial space. And so early this year, we announced the Universal Foundation of Measures. There are 2 behavioral health measures for adults. There are 5 for the pediatric population. This is the earliest, or certainly the early days, we're trying to see how successful we will be in terms of aligning across the programs, but we just think that that's very much a critical priority. So again, I'm happy to take more questions, but we just really think that quality measurement as part of our payment and reporting programs, as part of our models, is just a key consideration for having, for really seeking to improve the quality of care that our beneficiaries are receiving and being wise stewards of taxpayer funds. So I'll end with President Biden. If you look through his quotes, he likes to say mental health care can be life-changing and even life-saving. He also likes to say mental health care is health care. Our vision at CMS is for behavioral health that all people we serve across Medicare, Medicaid, and the marketplace have access to person-centered, timely, and affordable behavioral health care that is life-changing and life-saving, that can enable optimal health and wellness. And so thank you again for having me, and I look forward to the discussion.
Okay. These are tough acts to follow. And I should note that I am not a doctor. I'm just a PhD economist. And so I don't ask me anything that's actually very specific. I have to float at 30,000 feet. I want to start off by saying that many of the things that people are concerned about, complain about in the mental health system, things like workforce, access, fragmentation, these are ultimately all quality problems. Quality is the essence of everything that we're doing here. Everything is on your head, Dora. It's all you. And that's not unique to mental health. It's also true in the healthcare system as well. Tony pointed out that we're trying to do this value-based processes, quality-based performance all the way through the healthcare system. But one of the things that we know, and this is my frequent co-author Richard Frank and I always say this, all of the problems in the healthcare system exist in the mental health care system, only more so. Whatever you think is hard in healthcare, it's even harder. It's the same thing, but it's even harder in mental health care. And let me just lay out why it's harder in mental health before we go on, and then I'm going to stay at 30,000 feet and talk about other things. But first of all, it's really hard to know what's going on in mental health. There's not a lesion. There's not a blood test. That makes it very hard to do quality measurement, and it's very hard to audit quality measurement to see transparently into what's going on in the system. There's tremendous variation in the severity and nature of the problems people have within mental health. It's a very big category that has a lot of different stuff in it. Not only a lot of different kinds of problems, a lot of differences in the kinds of treatment people get, and way, way more difference in the kinds of providers giving that treatment in mental health than we see in general health care. And I should add, a really lousy literature on whether it makes any difference which provider type you see. So we actually know very little about whether it matters, whether people are seeing geriatric psychiatrists or social workers or anything. And that's a very big concern. And then there are strong placebo effects in mental health, which makes testing quality measures very hard. And there is this problem of the therapeutic alliance between the patient and the provider, which is uniquely significant in behavioral health. So all of these things make quality measurement and quality-focused care much harder in behavioral health than elsewhere. What I want to talk about today is kind of the challenges of existing quality measurement, and then actually throw out some really new directions and try not to spend too much time being the skunk at the garden party. So let's think about the existing measurements. The first ones that we think about really are outcomes. Are people doing better? In an ideal world, I think everyone would agree that outcome measurement is the way to go. But it's very hard to do here. We could directly measure outcomes, which is what we do in like drug trials of depression drugs and so on, self-reported depression scores. Providers ought to be doing this as a matter of course to see how people are doing. I would say they should also be measuring functional outcomes. How are kids doing in school? Whether people are employed or not, whether people with severe mental illness have housing. These are things that providers ought to be tracking. But I think they are very hard for measuring provider quality. They are costly and very incomplete. Not everybody is going to participate in these processes in a regular way. They are highly manipulable. And we've already seen that these things can be manipulated because risk adjustment in the Medicare program, one of the big challenges is often around behavioral health measure. So I think it's very hard to do standard outcome measurement of regularly measured outcomes. A second way to think about outcome measurement is to look at the really severe adverse outcomes, emergency room visits, inpatient stays, suicide attempts. There is some evidence, hallelujah, a little bit of evidence, that these really bad outcomes are avoided with better care. I have to say that the quality of that evidence is not what any of us would like it to be. We would be doing a lot better in this space if we actually understood more about how processes feed into outcomes. But if processes didn't feed into outcomes, what are we all doing here anyway, right? If we can't even figure out how we should be getting the better outcomes, then we're very muddled. We should be tracking these very severe outcomes at the provider level and at the plan level. We should make them very transparent. But they're not good measures for assessing individual providers or probably even plans. These are very rare events, so we need big samples. And there are real concerns about the incentives for avoiding sicker patients if you actually measure and report and incentivize things that are related to these very severe outcomes. Okay, so outcomes really problematic. What about processes? Are providers doing the right thing? Well, what on earth is the right thing? There is tremendous heterogeneity in treatment, so it is very hard to describe what the right thing is. It's really hard to map what happens in therapy offices to what the right thing is. When providers say they are doing CBT, the evidence suggests they might be doing CBT. We don't really know. It is costly and hard to map that kind of granular processes at any level. So instead, we go to kind of lowest common denominator access measures. Did you see a provider within 7 days after hospitalization? Or provider ratios. How many psychiatrists are there per so many members in your plan? These measures are not satisfying. I don't think they map either into effective processes or into effective outcomes. They're just things we can do. So what can we do that's better than that? I'm an economist, so I like light posts. I want to use utilization data because we've got it. I think that what we want to do is be more consumer-oriented in thinking about those utilization data. I was really struck by Teresa's remarks about using new sources of data. Can we look at utilization data in a more systematic way to see whether patterns of utilization reflect what we think is good care, not at the individual encounter level, but at the provider or the plan level? So, for example, are rates of diagnoses of mental health conditions what we would expect in this population or not? If a primary care doctor is never reporting diagnoses of mental health conditions, is something going on there that they're not actually catching something? Can we do that at the plan level? I think better than that even are rates of subsequent care, because this really gets at consumer choices. Do people who have an initial visit for a mental health problem, do they return to the same provider for follow-up care within an expected amount of time? So they have to do that. It's completely driven by the consumer. But if the consumer is not doing that, there's something wrong with the quality of care. That doesn't mean everybody should be returning for subsequent visits. That's not what I mean. But are we seeing rates of this that are compatible with what we think is good care? That will capture provider availability, and it will capture the quality of the therapeutic alliance. Maybe there are lots of doctors in the plan, but nobody likes them. That's not actually providing you with quality availability. Do people who have an initial diagnosis in primary care get a specialty care follow-up and then return to that specialty provider? Do people refill their prescriptions at expected rates? Do people see a second provider and a third provider, which suggests that they're not very happy with the care they're receiving? So I don't know what the measures ought to be, because as I said, I'm an economist, and I don't know anything about how you actually treat people. But I do think that we can think about measures that using data that we already collect, using utilization and encounter data that we already have to get beyond where we are now. Hard to do it at the level of the individual provider, although I think for some cases we can, but at the level of employer groups, Medicare Advantage plans, random assignment into Medicaid, we might be able to look at what reasonable care looks like in a population and develop some benchmarks. The goalposts will be changing all the time as everybody adapts to them, but I think this is a way to actually make a little bit of movement on a front that has been quite stalled. And I just want to add one plug, which is that this is also a way to capture equity, because we know about the characteristics of plans, so we can ask whether our underserved minority populations are going for the second and third and fourth visit when they should be. Are our rural populations getting this kind of care? I think there are things that we can do even with respect to equity using data we're already collecting. So let me stop there.
Well, terrific. Thank you to all of our panelists. I really appreciated each of your comments, and maybe try to see if we can have a little bit of a conversation both amongst ourselves and then invite members of the audience to ask us questions as well. You know, I was really, I guess I want to inject a little bit about some of my own challenges and how I've seen some of what's gone on here. You know, it was mentioned in my introduction that I'm still relatively new to KP. I'm coming up on about my 3rd year anniversary, and part of what attracted me to KP was the challenge that was given to me by our CEO, who said, I think it's time to really shift the conversation about quality toward outcomes. And we have really tried to move in that direction in cardiovascular disease and cancer care, in maternal health, and we're trying to do it in mental health and wellness as well. We are measuring things like response to depression treatment and suicide rates among our population and so forth. But you know, one of the things that wasn't explicitly mentioned that I just want to raise is that as an organization that maybe has a bit more infrastructure because of our closed network and ability to kind of really look at our full population, we're in a position to try to lead in this space, which is very exciting, and again, why I came to KP. But it's also a little bit scary in the sense that we're walking out on the ledge and we're doing something and beginning to put out information about our outcomes, and we've got no benchmarking because others aren't coming along with us. Are there ways that you can see to help entities like KP, others that are moving toward value-based care, to feel safe as they try to take the chances to move the field in different ways? I mean, all the things that you raised about the challenges, but can we create an environment that allows for the innovation to happen in this space without it becoming just, gee, KP, I don't think your outcomes look so good. And meanwhile, there's no context to evaluate, actually, are they amazing or are they mediocre or what? I mean, I personally think they're probably amazing, but, you know, it's very hard to know without benchmarking. So any thoughts about how we could allow the community to evolve by allowing leader entities like KP that are ready to take the step, and not sort of punish them for trying to do that?
Well, two thoughts about that. Number one is you do have a really unique capacity to apply measurement-based care. In many ways, as you think about it, really the way we treat patients should look more like the way we treat people with mental health problems should look more like the way we treat people with diabetes and hypertension and so forth, where we're keeping them in the system and making sure that we're tracking whether or not they're getting better. Just doing that is key. You know, one of the problems is if you look nationwide, there's a study that we did a number of years ago at episodes of behavioral health care. What do you think the modal number of visits is?
One. Okay.
Yeah.
That's why there's the potential to do
the
more.
the median is 4.
Okay. Yeah.
But that's, you know, but people drop out of care.
Yep.
We need to have what I term ruthless follow-up to make sure that they keep engaged. Not just ruthless follow-up, but also to make sure that we are doing some sort of systematic longitudinal assessment to see whether they're getting better. Not just for accountability, but also for how you're applying care, decision-making about what kind of care they should get. And administering that care. If people aren't getting better, you need to think about how do we intensify care. To have that kind of measurement-based care system. In fact, one of the things that I've suggested in some other forums is that we need to have, you know, in some ways a measurement-based care kind of, you know, label for places that do that and do that effectively. And then you're less out on a limb if everybody else is measuring in some ways.
Yeah.
And it's not just about some absolute value, but looking at improvement over time.
Yeah.
So, I mean, I think that creating these benchmarks could be done either by having everyone be required to create the benchmarks, but I also think there's a lot of data out there that you could use to describe benchmarks in different kinds of plans. There is a lot of utilization. I mean, one of the things I like about Lamppost is the data exists. You could do this, right? You could pull Medicare data and look at what's happening to people. And you could report what the national averages are and what you look like. At some point, there have been health systems at various times that have looked at these. I do think there's a lot of scope with these really severe adverse event indicators. They are not very manipulable. They shouldn't be happening. That doesn't mean that they won't happen. People die of all kinds of things. Things will happen. But you know, if you have elevated rates of these things, that's not good. You could look within KP and compare areas. And I think it helps you get to this linkage, which I think is so key between what the really severe outcomes look like and what the process of care needs, you know, that matches up to them looks like.
Yep. Yep.
So one thing I would add, I mean, it is difficult to be a leader in this space. When CMS adopts a measure, generally it takes from the time a measure is being conceptualized to the time it's in use in our programs is about 5 years. And so for those on the cutting edge, it could take CMS up to 5 years to catch up. But that is, and then there's also issues on the Medicaid side. As you know, at least half of states have to have the measure in use for it to be part of the course. I mean, there's a lot of different procedural barriers. But I do think that's part of the promise, frankly, for the CMS Innovation Center. I mentioned they have the INC model, pediatric behavioral health. We have the MOM model, maternal behavioral health. We're working on another model right now. But I didn't even mention, I mean, there are behavioral health measures that have been included and are Making Care Primary, our latest primary care model, other models. And even though it seems like a long time for models to go through, even as one model's launching, we're usually when you're already in the development of another model that's building on, iterating on the last successor model. And so that provides an opportunity to include new measures, to test measures, to really build upon what we're learning in the field so we're more timely able to, in many ways, at least for CMS, kind of push the edge. I certainly understand it takes a long time for the measures generally, because if you're going to condition payment on a measure, then there has to be some assurance of it being validated and effect, all of that, I understand. But I do think that there are opportunities at CMS to really think through how can we start to include measures that are being developed newer in this space. And I think to the extent when we include something, even in a model, our research models, we call them models, others might call them research projects or demonstrations, but we include that in a model, it gets a lot of attention. It is a strong signal that this may be one of the areas that CMS intends to pursue and I think could be a really worthy conversation.
Great. Well, thanks. I've also was struck, Dora, you were describing something I think that's a real step forward at CMS, which is to create the alignment across the different programs for measurement. So well done there at CMS, long time coming, but I think a good direction. Maybe tied to that a little bit, and I'm sort of curious about perspectives on this. Just when you look out at the quality measurement field, it seems like our approach has been, let's let 1,000, then another 1,000, and another 1,000 flowers bloom. And there's all these, you mentioned it yourself, there's 102 behavioral health measures at CMS. As you said it, I was thinking of that Bruce Springsteen song about how many cable channels there are, but nothing to watch. To some extent, do we need to almost get to less better ones as opposed to more? Or what's the process, that we see to get there? Is it just because we still haven't gotten it right, we still are in that kind of like innovation phase, or is there some value of thinking about let's hone it down and really figure out what things seem to be the right one? I mean, Sherry, you were trying to maybe go there a little bit. I'm curious, what's the best step forward for us? Is it still lots of things blooming, or is it time to start harvesting?
Well, I think the answer is probably a bit of both. I mean, we will say as part of our measure process, developing measures, we're also looking more about when we should be retiring measures. I mean, so as we learn more and know measures that are either topped out or ineffective, how do we get them off the list? And I think the Universal Foundation, I mean, that whole initiative in part gets at what you're saying, that there's too many, and if we can cull that down. And even for our MIPS program, if you're familiar with that, trying to think through what is a smaller set of measures that are highly relevant, particularly for certain conditions or certain provider types. So I do think you're starting to see us think about how can we start to shrink the measures filled so that we are focusing on those that matter the most. But that said, back to, I would say Dr. Pincus, he wasn't like, his presentation, the reasons why value-based care won't work. I'm not sure how many friends he made at CMS, but I do think, back to his slides and Sherry's point, it's harder to do in this space because the data and the evidence is just so limited.
Yeah. One thing we haven't touched on so much is how much telehealth has changed what's going on in this space as well. And I'm curious, whether you think this is truly an innovation in a sense? Is it going to improve quality? What are its impacts in terms of our ability to deliver and ultimately create the accountability around the care? I mean, what are the things that you're all seeing or hearing or your sense of this? I know it's still early and it happened fast, during COVID, but curious whether you see this as opening up new kinds of opportunities for measurement or assessment, accountability, and so forth.
So I think there's a couple of different things there. One is, obviously, it greatly improves the possibilities for both access and integration. I think the integration piece hasn't been exploited enough, but while there are lots of places that couldn't possibly co-locate a mental health provider, it isn't that hard to co-locate a connection to an online telehealth service. So You see a patient, and instead of sending them down the hall to a social worker, you send them down the hall to a room with a computer in it, and somewhere in Oshkosh, there's somebody who's on the other end of the computer. Just, it makes that way easier. I don't think we've figured out how to finance that or pay for it or anything, but it certainly raises all those possibilities. The other thing it does, and I think this is also a really, really tough thing that we're going to have to think through very, very carefully, and it kind of goes back to AI and so on. In principle, it can allow us to get inside the relationship between the patient and the provider. That really depends on what kinds of privacy protections we can enable. But you could imagine in another world, which I'm not even gonna, like, I'm an economist, I don't do this stuff, I keep saying that, right? That you actually record those sessions and run them through an AI machine and say, people do better when these are the things that happen than they do when those are the things that happen, not in an individual case. So I think there's actually great potential here on several levels. There's also enormous potential for misuse.
Just, I would say that there actually are companies that are doing that right now. So there are companies now that record these sessions and that extract three things out of the session. Number one is they're able to assess through AI whether or not what's going on in that session in any way resembles evidence-based care. Number two, it's able to abstract from that information also how well the patient is doing, to actually put together a kind of a measurement-based care assessment. And number three, they're able to summarize that session and enter it into the electronic record without the therapist having to write everything up.
Yeah, I think there's great potential for that.
Yeah, great. And do we know anything at this point about the effectiveness of care delivered through telehealth versus how it's delivered face-to-face?
Most of the evidence is that there's not a big difference.
Yeah, okay. Now, that
obviously,
would be
in certain
because
circumstances, there is.
Yeah.
But, for the most part, there's not a big difference that's been determined.
Fantastic. Great. I want to turn to the audience and see what kind of questions you have. Yeah.
Hello, I'm Clece Erickson from George Washington University, one of the couple of researchers in the room. And I've been doing a lot of workforce research around substance use disorder. And one of the things I recently revealed in a paper that came out in JAMA is that when the waiver was a thing, only 40% of providers with the waiver actually prescribe buprenorphine in a given month. And many drop out or never prescribe. And so I'm a little worried now that the waiver's gone, which I think is an excellent thing. Is that going to be enough? And your conversation today made me wonder, is there a potential measure around that could be developed around if you're a primary care provider and you have a patient with a diagnosis of opioid use disorder? This possible process/quality measure would be like, what % of your patients with opioid use disorder are on buprenorphine? I think because that is the thing that should happen, and you could maybe make exceptions for
and stay on buprenorphine for some period of time and have follow-up visits. And it seems to me like there's a lot you could do.
It seems like that is potential for a measure.
And even though I think CMS is really important and all of that is really important, a lot of this should really not be coming from CMS. A lot of it should be coming from health plans doing it themselves.
Absolutely.
Yeah.
I don't think you should be waiting for in fact, it almost would be better if CMS could see how these things are working in the world and then decide which ones of them it wants to adopt for payment purposes, as opposed to straight up quality improvement, which is not about payment, but just straight up quality improvement.
And to that effect, I think group practices could actually do the same thing, hold their workforce accountable for doing this. Can I add one other comment too, which is I've also identified through my research that primary care providers, as you all mentioned earlier, are a big part of treating health workforce, including for serious mental illness. And I haven't heard any mention yet today of hub and spoke models or e-consults or Project Echo, and I was wondering how you all think that might fit in with quality.
I would say for CMS, as part of the CMS Innovation Center, they released their specialty integration strategy. I'm not sure the right term. It can be found online. But thinking through how they can more strategically use the different models, including e-consults, as you mentioned, other models, to expand the footprint. That's definitely been contemplated, and they're trying to think through how can they include that approach in more of the models. But at the same time, though, I know that there's a lot more that we probably could and should be doing in this space.
You know, I just wanted to comment, you know, one of the things, thank you for bringing up the primary care issue. One of the things that we're doing at KP is it's really trying to roll out the collaborative care model, right? And to partner behavioral health specialists in primary care settings and to really bring that expertise, you know, to bear in a timely way. But it is striking. I mean, that model's been proven to be very effective. Actually, we've known that for quite a long time through a lot of studies. And yet, if you look around the country, its uptake is extremely low. And it kind of speaks to some of the challenges we have around trying to move evidence on delivery models into care, right? If collaborative care had been a red pill and we got it through the process, the FDA would have approved it and everyone would be taking the collaborative care red pill years ago. And so it really speaks to a challenge I think we have. And I'm curious, are there ways to accelerate when we have delivery models proven to be effective, like collaborative care, using primary care with behavioral specialists to move things along more quickly?
And I don't ever want to speak for my colleagues in Medicare, but they have released a payment code for collaborative care as one way to try to incentivize, but it's still, you know, just one small step. And from the way that Sherry's shaking her head,
I think
step.
the challenge is that trying to incentivize institutional change by changes in marginal payment rates is a really tough game, right? That's just you're not asking people, so the doctor doesn't even get reimbursed for prescribing Prozac. Prozac and collaborative care probably started at the same time, right? Collaborative care went nowhere, and in 2 minutes, Prozac took over. Not only did Prozac take over, what I find really interesting is that before Prozac came on the scene, the question we were all engaged with is, why don't primary care doctors diagnose depression? They don't ever diagnose it. And then Prozac came and they began to diagnose it. And so that actually tells us something, right? What does it take to make this happen? It takes the primary care doctor feeling like this thing is actually making me be able to do my job that I do every day better. Not that I get paid for it more or anything, but my patient comes to me, they want something from me, and this thing enables me to do it for them. And that's what led them to start screening for depression. We taught them a million things that didn't work. We did like payment, didn't work. Finally, they had the little red pill, and they were like, you know what? I write this thing, and they feel better.
Yeah, well, ease of administration has been noticed in other businesses, and so I do think that that's a good point. Yeah. But I think primary care doctors do believe in collaborative care, but at the ease of being able to implement it is...
It's really hard.
Yeah.
Well, I think part of it is that you're paying for a team.
Yeah.
And it's hard to pay for a team. And I think that's really, unless you're in an organization like KP, where you by definition, you're a team, it's hard out in the sort of real world of, wild world of practice to actually pay for a team. And that's, I think, the real challenge. I think the other issue is to think about how do you really engage, even now with the collaborative care codes, how do you make it easy for them to actually get paid? Because I think that's really the challenge that you hear out in the field. The other thing to think about is, again, thinking about it from an integrated care point of view, is how do you get better general health care, preventive health care, chronic disease health care for people with serious mental illnesses. There's very little incentive for even to have people like that in your waiting room as a primary care doc. Yeah. I remember when I was, working at the Community Mental Health Center, it was really hard to get my patients into primary care practices. Yeah. And actually to keep that as a kind of a quality measure, there's actually a fairly simple strategy. We do, for people, for example, that have both diabetes and psychosis, we can look at whether or not looking at the diabetes measures at the segment of people who have psychosis and see if there's a difference. So that, if you're looking at hemoglobin A1C, is there a big difference between the segment of people? It's like a disparities analysis. Yeah. Between people with serious mental illnesses in terms of the way in which their hemoglobin A1C is going. Or for that matter, what about their immunizations? What about their cancer screenings? Mm-hmm.
Yep. Well, you've provided a perfect segue to bring this panel to a close. One is you said the team is important, and we've had an amazing team here. And so, first of all, I want to thank this team of panelists who've done a great job to bring out the important issues around measurement and improvement in mental health care. And Dr. Pincus, you also highlighted some of the workforce challenges, both on the mental health side and just mentioning primary care as well. And we'll be having a panel after lunch to talk about some of these workforce issues. But please join me in thanking our panelists, and we'll exit the stage. So thank you.
Thank you. Thank you, everybody. And yes, thank you for the panel. That was a great conversation. Wish we could have given you a little bit more time, but we are going to transition to lunch. So lunch is being served in the back of the room. It's buffet style. We'll encourage you to come back into this room and eat and have conversation. And if folks came in but haven't yet registered, I would ask if you could please take a couple minutes and go to the registration table and make sure that you've registered so we know who's in the room. And we will begin the program promptly at 12:45. And I'll give you a little bit of a notice, but please enjoy lunch. Thank you. Great. Great, thank you, everybody. So I'm excited to introduce that our final panel is about to begin. We'll be focusing on workforce, access, and diversity needs. And I'm honored to have our KP clinical leader, Dr. Karen Stewart, moderate this panel. So let me tell you a little bit about Dr. Stewart. She is the Chief of Behavioral Health for the Southeast Permanente Medical Group. In this role, she's responsible for development and implementation of the mental health and wellness care delivery system for Georgia's 320,000 members. Dr. Stewart is a champion of integrated mental health into primary care settings through her role as the National Clinical Lead for Collaborative Care for Kaiser Permanente. Her leadership centers critical work such as creating a zero suicide and overdose culture, focusing on measurement-based care, and providing delivery innovations like digital therapeutics. Dr. Stewart's is board-certified adult and child adolescent psychiatry who received her BS in chemistry from Spelman College and her medical degree from Morehouse School of Medicine. She went on to complete her adult psychiatry residency and child and adolescent fellowship at Emory University. Dr. Stewart has served on the boards of trustees for Morehouse School of Medicine and the Georgia Psychiatric Physicians Association. So welcome, Dr. Stewart.
Thank you so much for that introduction. Like, I sound far more impressive than I feel on an everyday basis, so I appreciate that. Good afternoon, everybody, and welcome back from lunch. I know that after lunch, you know, all of the blood is going straight to your gut and not to your brain where we might need it to be. So if you feel like you need to rise in body or spirit to shake things off and be engaged with our panel today, please feel free to do that along the way. So, this afternoon, I am privileged to be moderating a panel on the mental health workforce with a group of esteemed panelists. As we take a deep dive into the future of mental health and addiction services in this country, it is particularly important to examine the development and sustainability of our mental health workforce. For decades, policy and workforce experts have been concerned about the shortage of mental health professionals as the need for individual needing mental health treatment rises and outpaces the number of mental health professionals available. Before the pandemic, the U.S. Health Resources and Services Administration predicted that the U.S. would have a shortfall of mental health and wellness providers of more than 350,000 by 2030. Deficits in our mental health and addiction workforce manifest in long wait times for appointments as instances of anxiety, depression, and suicide increase. We are approaching a breaking point. I feel it when I'm looking under rocks and around corners when I'm recruiting, and you all feel it when you're waiting 3 months for an initial appointment or a return appointment. Fortunately, though this sounds very bleak, we have experts like our esteemed panel working on viable solutions to help bolster our workforce in innovative ways that expand and diversify the behavioral health workforce and make access to care easier for our patients. So I'm going to start by just giving a brief introduction for our panel. We have Dr. Anna Rotzliff, Dr. Parinder Khatri, and Keris Myrick with us today. I'm going to introduce each of them individually as they give their remarks, and I'll start with Dr. Rotzliff. So Dr. Anna Rotzliff is a national expert on collaborative care with a specific expertise in training teams to implement and deliver mental health treatment in primary care settings. She is currently a professor in the Department of Psychiatry and Behavioral Services or Sciences at the University of Washington, where she developed additional expertise in mental health workforce development, suicide prevention training, adult learning best practices, and mentorship. Dr. Rotzliff is the co-director of the AIMS Center and director of the University of Washington Integrated Care Training Program for residents and fellows. Please welcome Dr. Rotzliff to the podium.
All right. Thank you. Okay, I'm very pleased to be here and talk a little bit about innovation, hopefully to close the gap around behavioral health workforce. And since I'm the first person up, I always like to give a little context. I think we've already been talking about a lot of these facts today. I think it's helpful to think about the fact that more than half of the people who want care don't get it, right? So to me, that's really a very important context, and I think behavioral health workforce is a big part of the limitations in access. I also think it's important to talk about that we really have broad needs in behavioral health workforce. So these two slides are really to just illustrate. The first one was a study that looked at access to prescribers and found that most counties in the United States, 96% have some level of unmet need for prescribers, which means there's not enough people available to prescribe evidence-based treatment for mental health disorders. The bottom figure is actually from during the COVID pandemic. They did these pulse surveys where they were able to actually kind of do snapshots of what is access to care looking like. And it was actually looking at access to psychological treatments or therapies. And there's also a huge unmet need. It varied across the pandemic and it varies county by county, but essentially, you know, it's also hard to get access to like our evidence-based psychological treatments that we know are effective for our patients. So, you know, I think it's also important as we start to talk about workforce that this isn't just specialty behavioral health providers. There's a whole continuum of behavioral health care settings where people are accessing care. Everything from community-based settings to integrated care in primary care settings to our specialty behavioral health settings. So I think it's also important. People will often talk about lack of a certain amount of workforce in a specific area, and I think it's hard to just look at one area because you really are having to look across that continuum. Because of course, if you can give more access in settings like primary care or the community, maybe that can pull some of the burden off of our specialty care settings, for example. So it's going to be really important as we start to think about workforce, what are all the levers and strategies we might be able to use? I also think it's important to broadly define the workforce. I purposely made this not a hierarchy because I actually think all of these folks contribute to what we might do in terms of increasing access to behavioral health. And these include people like our prescribers, our delivery of therapy, more formally trained behavioral health workforce. This also includes people who support patients, like their families and caregivers, other people in the community. It also includes people like our primary care workforce and other partners. So I think one of the things I really am challenging all of us to think about is who are all the people we might be able to recruit in to help us with some of this very important lack of access to care. So I wanted to give 3 specific examples of ideas because I think this was part of what we were hoping to do is actually generate ideas around especially policy levers that we might use to fill some of the behavioral health workforce gap. So I work in collaborative care. This is my area of expertise, so I'm going to talk a little bit about collaborative care. And I think this is an important strategy because I think there are several different ways we can actually increase the workforce. And I kind of created this diagram because I've been trying to wrap my head around where all the places we might have levers to improve and fill that gap, right? So the three areas that I'll talk about are all things that could really increase the available workforce. I don't want to in any way devalue some of the things that are also very important in retaining our current workforce. I think we are also hemorrhaging people. I'm not going to focus on that today, but I just wanted to acknowledge there's another part to my diagram here, because I think those are other places that we might be thinking about policy innovations. So in collaborative care, I think one of the things we've seen, and it was talked about, that is an evidence-based model, but has not had as much uptake as we would hope, or not as much as Prozac. And so, what are some of the levers that have been used to try to promote that? So I'm going to talk about those first. I think that these are really important strategies because integrated care, collaborative care is a way to teach your workforce new ways of working together so that they can expand the number of people that they're impacting. And so I will show you that on the next slide. So this is basically training in new skills, right? How can we take our existing workforce, give them new ways of working to actually expand how many patients they're able to touch or support? So in this model, just as a quick reminder, the primary care provider serves as the main prescriber, really owns that patient relationship with the patient, and they are partnered with a behavioral health care manager, often a master's level person, who has training in both psychotherapy but also in care coordination, and then often use a psychiatric consultant who has that prescribing expertise, who doesn't see patients directly, but rather leverages their expertise through that team to be able to actually serve more patients. So when I did this work, instead of seeing 8 to 10 patients in a clinic by myself, I would support 3 care managers in a day that each had a panel of 60 to 80 patients, right? You could see my work would be leveraged a lot more in that situation. So what are a couple of policy levers that have helped with this kind of structure? The first was one that was already mentioned today, that CMS started offering Medicare payment for collaborative care. These are some of those codes and their reimbursement rates. I think it isn't, a panacea, but it has offered a lot of practices, a way to practically start moving in this direction. And we've also seen that establishing those codes has led to Medicaid in many states also adopting codes or payments for this work, as well as seeing many private commercial payers also starting to pay for this work. So creating an infrastructure and a way to actually pay for team-based care, even though it's a little awkward, you're trying to use our fee-for-service system, has been really powerful lever to start increasing opportunities for this kind of care. I also think one of the things that we found is that it's very important to support implementation. I think that is one of the reasons why it's been hard. It's not quite as simple as just prescribing a new medication, right? You actually have to figure out how a whole team of people can actually work together in new ways. And so we've seen also some legislation in that area. This year there is federal legislation trying to look at maybe increased payment rates for the first few years that people are billing these codes, for example, as a policy lever to really incentivize people to take that investment and actually start delivering care this way. The next, lever that I'll talk about a little bit is, creating new types of providers, and I think we already heard a little bit about that as something important to be thinking about when we were talking this morning. I'm going to talk about a specific policy innovation that we've been working on in Washington State. We've decided to work on creating a new behavioral health workforce called a behavioral health support specialist. This is going to be a bachelor level provider that is trained to deliver evidence-based therapy to address common mental health disorders. They are not going to have within the scope of practice to diagnose, so they would have to be working under and closely with someone who had that scope of licensure. This has been a really complicated project to work on because we've had to simultaneously work on policy, curriculum, and practice changes to really try to foster the adoption of this approach. But I'm very pleased to say that last year the Washington State Legislature approved, creating the scope of practice, and we're literally in rulemaking starting next week on what this will actually look like. And this is based off of a very successful model from the UK called the Improving Access to Psychological Treatment, whereby creating this kind of provider that had a lower barrier to get to start practicing actually has dramatically increased access to psychological treatments in their country. So I think we need ideas like this that we're bringing into the United States, and I'm really excited about this particular opportunity. And lastly, I'll just talk a little bit about how do we actually, if we're actually talking about trying to increase the number of people that are in our current training programs, what are some of the things we need to be able to do to support that work? And I'm going to talk specifically to supervision. I was the residency program director until June of this year at our university, and I can tell you getting people to supervise, we expanded actually our residency program under me. We added 16 additional psychiatry residents. It's now the largest psychiatry residency program in the country, but it was a lot of work for faculty to supervise those additional people. And so I want to talk a little bit about some policy opportunities that might be helpful to be thinking about if we're going to try to also fill up and expand the number of our current traditional programs that we're doing. The first thing is, most of the time, there's a lot of variability in how much supervised practice people need to be able to go into practice. And so one of the things our state has been looking at is, what is the variation for equivalent types of providers? For example, there's different numbers of hours that are needed to actually become licensed for a licensed marriage and family counselor compared to a licensed social worker. And why is that different? We don't actually have a lot of data on that. And so I think it's actually really important to challenge. Just because we've been doing it that way for a long time doesn't mean we should keep doing it that way. And we should be looking at those numbers. We should be looking for data to inform how long should we actually be doing, expecting people to get supervised practice. The other thing I would say is that I think it's also important to think about, are there ways to pay supervisors while they're supporting trainees? I think there's this misconception that when you have a trainee, it's going to help you be more productive. I can tell you right now, as someone who does this, it slows me down. I can see way more people by myself than when I'm training a resident. And we need to have some way to get paid for that time. Interestingly, for primary care provider, there is a primary care exception for Medicare, where even if that supervisor isn't directly with that person, they can still bill for those services. And that doesn't exist for psychiatry residents, for example. And so could we look at some of those policies that have promoted, specialties like primary care, and think about that as a way to try to create more incentives for providing supervision and increasing the number of people we're training, because I think otherwise people are going to really struggle to do that. So I hope that these were a couple of good ideas that you can take back, and happy to talk about them when we do our discussion.
Thank you so much. Next to the podium, we have Dr. Parinder Khatri. Dr. Khatri is Chief Clinical Officer at Cherokee Health Systems, a comprehensive community healthcare organization in Tennessee that is a federally qualified health center and community mental health center. In this role, Dr. Khatri provides oversight and guidance on clinical quality, program development and management, workforce development, clinical research, and clinical operations for blended primary care and behavioral health services. Within the organization, she is also the principal investigator of several research and education programs at Cherokee Health Systems, including NIH-funded All of Us research program and Community Engagement Alliance Against COVID-19 Disparities. Please help me in welcoming Dr. Khatri.
Thank you. Thank you so much. I'm delighted to be here, and I'm going to give really the provider perspective as both a FQHC, or federally qualified health center, and a licensed community mental health center, just to give you a level set from my perspective and a little bit about who we are. We are based in Tennessee in the Smoky Mountains, and we actually focus quite a bit on offering like a continuum of primary care, behavioral health services. We also have optometry and dental services. As a safety net healthcare provider, health equity is kind of a running theme across everything that we do. And virtual health, training and education, we had to get into because these are things that we needed to help us do our job. A little bit about our snapshot. We were established in rural Tennessee in 1960. We started out as a community mental health center. So it was just this tiny little open on Tuesdays and Thursdays child guidance center. And it was in 1983 that we expanded into primary care. We really did it because of patient need. No one would see our patients for medical care. We would be in these areas, and the primary care docs would say, oh, that's a Cherokee patient. They have a mental health problem. I'm not going to see them. So at the same time, we worked with the Bureau of Primary Care and started putting behavioral health providers in their primary care settings. The behavioral health providers came back and said, we are seeing just as much psychopathology in primary care as we are in our specialty mental health care. So since the early 1980s, we worked on developing a model that was very much community-based, team-based, and frankly, innovative out of desperation. Everything we've done really that's been innovative is because we've been desperate to solve a problem. We even started doing our telehealth. We're now 21 years into doing telehealth. We originally used T1 lines. And I don't know if you remember the Max Headroom, like that was our psychiatrist. He built our first telemedicine unit from the clearance rack at Lowe's. And now, of course, it's, we use Zoom, et cetera, but that's how we were able to get psychiatric services to the most rural areas in Tennessee. We see about 67 to 70,000 patients across 13 counties. We also have another 20 plus virtual health school-based sites. Somebody had talked about school-based in collaboration with schools. We have some counties, in fact, the county where Dolly Parton grew up, Sevier County, where we have 27 schools across 280 miles of mountains, up and down, where we provide virtual integrated services. And our population is quite diverse, believe it or not. We have patients in rural Appalachia. We have urban settings, we have homeless health, we see new Americans, refugees, and African American, Hispanic, Latino. So what I want to just convey is we have had to adapt our behavioral health services to meet a variety of populations and a variety of needs. So here's a little bit about how we have done that. One thing that has been clear to us is that people show up for behavioral health in different settings, and we can't expect everyone to fit our way. So we say there really is no wrong door. We have integrated behavioral health in primary care. We have integrated clinical psychologists, licensed clinical social workers, licensed professional counselors, LMFTs, really embedded as part of primary care. Their job is to manage primary care patients. We also have consulting psychiatrists or consulting psych nurse practitioners for the medication management and just general consultation. But we also provide this, what you would consider all the trappings of a community mental health center. Case management, care coordination. We have a day treatment program. We have a substance use disorder clinic and a series of them, and some are really embedded in our MAP program. We've got one embedded with our OB program, because we have so many pregnant people with substance use disorder issues. And we had to get a psychiatrist who had specialized training in management of pregnant people with psychiatric issues. Peer support has been unbelievable for us. We probably have grown that by 4 times in the past 6, 7 years. And we have a number of peers. Also day treatment. And I also want to just give a shout out to individual placement and support. For those of you who are not familiar with that, that is a kind of a supported employment. So people who have behavioral health conditions can work with our ISP counselors, and we have connections with businesses, because meaningful work is actually an important part of overall health and mental health. And that's really what we see from the research. So as you're seeing, we have a continuum of behavioral health services. So what do? What are the different functions and roles? We have expanded quite a bit of who can do what, but in general, what we have is our specialty therapists, our licensed clinical psychologists, social workers, licensed professional counselors, licensed marriage and family therapists. Our peer program has exploded. We have peer wellness coaches, peer support specialists, peer recovery specialists. I will tell you, our peers saved us during the pandemic. We had 2 groups who saved us during the pandemic. One were our peers. The 2 was this behavioral health assistant, which was a category that we developed. We thought we developed it, but I saw, Anna, you have that, so I guess it wasn't that unique. But we needed somebody who could be the glue, help support the care plan, do a lot of care coordination. Our peer recovery specialists, our peers who are in the state of Tennessee, we actually can get them certified. So they're certified, they go through training, they have supervision. They were placed in the emergency rooms before the pandemic to help link people who had come in with overdose or any OUD issues, any SUD issues. And then when the pandemic happened, they were kicked out of the emergency rooms. They just said, we can't have people in here anymore. And then they came and just sat with our team, and they jumped in and they made phone calls. They helped triage. They were out screening. They were our high touch for our patients who were most at risk. And those were patients who had a very strong structure of support between our IOP, NA, AA, et cetera. And all of that had vanished. All of that had vanished during the pandemic. So the risk was really high. And then we have our psychiatric medication management. And as you see, we have a quite broad group of people who prescribe. And it really, I think, is grounded in our strong consultative psychiatry model, because we have OBGYN providers, addiction medicine physicians. We have primary care providers who feel comfortable, much more comfortable, consulting with a psychiatric consultant and then having psychiatric med management. I will tell you, the most comforting thing that they can hear is, I'm here if you need me. I can see this patient, I can stabilize them if you need to get them back. And I think that infrastructure has been really important. So what we're able to do is preserve our specialty resources. We talked about that. We don't have enough specialty resources, so we need to preserve them for the patients who need them the most. The one thing I will add that's important is, traditionally in behavioral health, it's been a one-way model. You refer someone to a specialty behavioral health provider. If you're primary care, one of our primary care docs who joined us said, usually it was like sending a message in a bottle. I never knew what happened. I didn't know what meds they were on. I never even know if they showed up unless I asked again and again. So what we have learned to do is be very intentional about the bidirectional flow. Because when people stabilize, because believe it or not, having a mental health disorder is not like a sentence for the rest of your life. People can improve. This is an undulating course that people experience. And when they are more stable, you have to intentionally reabsorb them into either primary care or a setting where you don't need the same level of intensity. This is really hard for for people who have gone through years and years of training to absorb. Because they will say, well, this is my patient and I've stabilized them and it's now an easy patient for me. But the reality is we need to open you up for the next round of patients. And that population health mentality has been something that we have had to train in our staff, because most training programs, including when I went through training, only train you to work in your silo and to think about your caseload. Now, when we get providers, we have to basically give them a crash course on population health. And what does it mean to work as part of a team? And how you can contribute to the improvement of an entire population, not just the people who you like on your caseload or your schedule. And that is very challenging. And we have to really think about that as a culture. And then we've developed some pretty robust clinical analytics. So people know, you've seen this person for X long, this is how their measures look. Do you really need to keep seeing them, or can they be transitioned to another group? Okay, so in terms of workforce recruitment and training, we realized 40 plus years ago, we are a nonprofit. We're many of our settings are not the most desirable settings for people to live. We don't have people knocking down our door wanting to work with us, at least at that time. So we started our own training programs. It was the most selfish thing that we could have done, and it is the most selfish thing that we do, because so many of our current staff were trained with us. It is the best job interview in the world. And so we partnered with multiple programs, multiple academic entities. You'll see nurses, family medicine docs, psychologists, clinical social workers, you name it, nutrition students, we have it all now. And I will say another thing that we had to learn is we had to build in boot camps for people who were retraining in the integrated care model. So particularly, for example, our psych nurse practitioners, most of them have not been trained. So they usually don't even write prescriptions for the first couple of months that they are with us. They train. Our director of psychiatry has created her own little boot camp because the investment early on is worth it. We don't really want them to learn that much on the job, because if you stumble too much when in integrated care, you lose credibility. So we create those, we really create a lot of infrastructure and support. We've learned it because we have battle scars. Every single time, we have shortchanged training. And we have shortchanged training a lot because we just want to get someone in the office, get them on the floor, get them seeing patients. But every time we've done it, we pay for it. Every time we've done it. So we said invest early on. And as you can see, what we've had to do is also build an infrastructure around what we consider professional quality of life. So that's been really interesting to do in an integrated setting. So you have our ballot groups, if you're familiar, they're actually co-run by one behavioral health provider and one primary care provider. This is probably the slide that I want to drive home the most in terms of meeting the need of the workforce. What are the facilitators and what are the barriers? The facilitators are so much of what we've talked about. We've got a diversification of a workforce. We've expanded what people can do in an acceptable and appropriate manner. We are seeing more uptake of integrated care, and we're starting to see some movement. We talked about value-based payment. We're starting to see some movement in advanced payment models. And for us, as an FQHC, we track, anyone who's familiar with UDS, the Uniform Data System, we track like 60 plus metrics. We also have to track metrics as a community mental health center. We're also an alcohol and drug treatment center. When we look at those metrics, even all the medical metrics, we assess them based on the performance of the team. So if you're a psychiatrist or psychologist or any behavioral health provider, peer recovery, you get those metrics for diabetes management. You actually get them for, breast cancer prevention, mammogram. This is a team outcome. So we want and need better behavioral health outcomes, but we actually look at it as a whole. The barriers drive me crazy. The barriers drive me crazy. Reimbursement has been stagnant. We have commercial contracts that the rates have not been updated since 1994. 1994. It is like, I was going to say it's like an act of Congress, but it's very hard to renegotiate your commercial rates. The bureaucratic complexities are very challenging. Just getting behavioral health providers credentialed is hard. In the state of Tennessee, for Medicaid, if you're FQHC, you're supposed to get credentialed, fast-tracked, within 30 to 60 days. That is not enforced. So we have psychiatrists, psychologists, clinicians. We have people who we've had on staff for 4 months, 6 months, 8 months, a year and 2 months, where they are not credentialed. That credentialing is a payment issue because any claim we submit will get denied. So when you talk about access, you also need to realize for many, many years, we were seeing people no matter what, but we were not getting paid. And payers would say, hey, we don't have to credential them. They'll see them anyway. And, you won't get paid. But for a nonprofit or frankly any health system, you can't keep doing that. It's not sustainable. But we are having significant barriers with credentialing. The devil really is in the details. And I'll wrap up with just a story just because it came to me when Dr. Pincus was talking about the 7-day follow-up, hospitalization follow-up. So here's an example of when we tried to be creative. We worked with different psych hospitals, but we had one psych hospital that agreed to let us set up a telemed unit in their hospital. And this was before Zoom, this was before the pandemic, this is when we were using Polycom. And we set up block scheduling, so when someone was being discharged that morning, they're getting discharged from the psych hospital. Via virtual health, they would see the case manager, the therapist, and the psychiatric provider. We had 100% follow-up for that 7-day for that hospital until someone found out that if we billed for our outpatient follow-up services, the hospital was not getting paid for that discharge day. And then once that was identified, they said, you can't be here anymore because we don't get paid if you see them that day. So when you talk about bureaucratic complexities and all these issues, and particularly within the context of payment reform, the payment and incentives have to be aligned across all the continuum, and that has yet to happen. So I hope what this has done is given you a little bit of a sense of how we have had to be creative with our workforce in training, education, and development, but also some of the real nitty-gritty challenges that we are experiencing as a provider, really trying to meet an almost unrelenting demand for behavioral health services. Thank you. Oh, thank you.
Thank you so much for outlining some of the challenges of managing our workforce. To round out our panel today, we have Keris Jän Myrick. Keris Jän Myrick is the Vice President of Partnership of Inseparable. She previously served on the board of and is currently a policy liaison for the National Association of Peer Specialists and the Board of Directors of Mental Health America. With over 15 years of experience, she is a leading mental health advocate and executive, known for her innovative and inclusive approach to mental health reform and the public disclosure of her personal story. Please welcome Dr. Myrick. I'm sorry, Ms. Myrick.
Oh, you can call me Dr. Myrick. Shoot. I'll take it. Okay, y'all still with us? Yeah? Oh, I'm not using this. I'm using this. Wait, what? You're still with us? What? I didn't hear anything. Then you're going to make us do the work. You might as well participate, right? All right, so I'm going to talk to you a little bit about peer support and the work that I've been doing in the area of peer support over the past, like, gazillion years or so. And I wanted to start off with a little snippet from Dr. Miriam Delphin-Rittman, who is the Assistant Secretary for SAMHSA. Hopefully this works.
To truly meet the needs of individuals that are having challenges. And, you know, I love that mantra, nothing about us without us. When I was commissioner and in my work now, I try to have that at the center of our work. And so the recovery office is very much about that, you know, involving individuals with lived experience in the work throughout SAMHSA. And coming up with strategies and approaches to advance recovery from an individual program perspective, but also a system perspective as well.
So out of the Office of Recovery, there's a lot of work that's happening around peer support. And so I like grounding it in her vision of what the office is, and point of disclosure, that is her on my podcast. So that's point of disclosure. So how many people are familiar with what peer support is? Okay, and you actually explained it, so I am done. I think that was my presentation. But basically, peer support is somebody, of course, with lived experience who uses that experience along with training in order to provide support to another. It can happen by being a certified peer support specialist. It could happen by being a mutual aid like AA, where you don't need that kind of training working in the community. It's been very confusing to the field about exactly what is peer support, who does peer support, who supervises peer support. So before we can even get into what may be some policy recommendations to advance, I think it's also important to understand a little bit about where we were and where we are. So because it was really hard for people to kind of wrap their head around what peer support was, back in I believe this was 2017 or 2018, we actually, at SAMHSA, which is where I used to work, by the way, we created through the Bringing Recovery Supports to Scale Technical Assistance Center strategy. That's the government for you, brass tacks. We created these value of peer support. It's very hard for people to kind of wrap their head around advancing peer support because they didn't know what the evidence of peer support was. So we would get called a lot and, oh, what is the evidence? Can you send me a lit review? No, I don't have time to send you a lit review. But what we do have time is to give you these kind of infographics that talk about peer support, basic peer support, mental health peer support, addiction, and then also family and caregiver peer support. So if, I want people to be able to access these documents should they need them. They're really, really helpful, and I've actually seen legislators use them when they're trying to advance legislation related to peer support. So on the front side, it talks about what peer support is, and on the back side is a mini, if you will, lit review about what are some of the outcomes related to peer support that are evidence. Well, I would say based on evidence. I don't know that evidence-based is quite the right word. So these came out in 2018. And also in 2018, because of the 21st Century Cures Act, the GAO examined mental health peer support. And, really the essence of why that happened was the belief that Medicaid and the government should not be funding peer support. That's actually why they asked GAO to do the report. And actually what happened is the GAO found that there are 5 leading practices for certifying peer specialists as they looked across the states at that time. And that was put out to the field. And then in 2019 was a separate report on SUD, recovery, coaching, and Medicaid. Whoops. I'm like skipping ahead of myself, I believe. All right, so also in 2018, SAMHSA released the National Core Competencies for Peer Supporters, again, to help the field have a better understanding of what are some basic guidance that we could provide across the states as they started to set up their certification practices. In order to bill Medicaid in 2007, CMS, gave guidance to the states about what the things were needed in order to bill Medicaid for peer support. One is around having core competencies and training. The other is around supervision. There was also what is the age range of a peer supporter and what are the educational backgrounds, prerequisite educational backgrounds. And I'll talk a little bit about that. So in 2018, SAMHSA created these core competencies for peer supporters because of the variability and to help states kind of align a little bit better. They didn't have to undo what they were doing, but certainly to align. So one of the things we've never understood is who are they, what are they doing, where are they? We still kind of don't know that, which I think is a bit of a barrier. How do you advance something when you don't know how many there are and where are they and what do they look like? So we have a general idea that peer supporters tend to look like the communities they serve. So I think when we're talking about equity issues, when we're talking about being able to see somebody as a person with lived experience, see somebody who looks like you, who's been through what you've been through, especially if they're not providers of colors, for example, peer support is one way to think about advancing the diversity of the workforce, but quite frankly, we don't know exactly how many peers there are across the country. We think 20,000 from a recent study that is still, it says between 20 and 30,000. Well, that's a big sort of plus or minus, right, of 10,000, but we don't exactly know the diversity of this workforce. So this is actually a KFF link that I think is really great for people to look at. It provides data that you can search state by state, information about Medicaid and peer support. Now, not all peer supporters bill Medicaid, so this is giving you a slice of the pie. You may have peer-run organizations that are grant-based, that are funded by philanthropy. They may not be billing Medicaid. And then you have also your mutual aid like AA and the like that are not captured up in this, but this at least gets us started in looking at what states are Medicaid reimbursable and what aren't. And I actually was doing this presentation for I think it was CSG, Council of State Governments, and there's kind of one mistake here, so that's okay, but basically there are 41 states where peer support are covered, there are 5 that they're not covered, and that there are 4 in which they did not get any response. Now, what was interesting when I gave that presentation, I kind of wanted to know, why aren't they covered in a particular state? And I didn't call the state out, I just called the states in, like, hey, 5 of you aren't, you know what I mean? And so a couple came up to me, and one state said, our peer said that they don't want it. So I think we can't say that it shall be, but we have to hear from the communities, how do they want to do it, versus saying, well, this should say, all states. Maybe it shouldn't, but we should understand why states aren't doing it. At Inseparable, which is where I work, we have Hopeful Futures campaign, and one of our Hopeful Futures campaign partners, let me tell you, Hopeful Futures campaign is about school mental health. They were very interested in youth peer support, and I heard somebody talk about that earlier. I don't remember who it was, but they actually took a look to see where are youth peer supporters and are they billing Medicaid, what does that look like? And so this came for the Center for Law and Social Policy, which is one of our HSC partners, our CLASP. And their report was released just recently in 2023. And basically, they found that 18 states allow for Medicaid billing of youth peer supporters. Now, the recipients of those peer supporters varies for state to state. So for example, for some states it can be 18 to 26. For some states it's below 18 with the lowest being 13. Pennsylvania, for example, is 14. So there's still some variability, and I think that's something we need to keep our eyes on and need reporting about. The other area is, crisis. So we would have you listen to her, but we're going to go ahead to make sure we have time for Q&A. But where are peers being utilized in crisis? You can listen to my podcast if you, okay, shameless plug. But anyway, so we also want to have a better understanding of what are the rates that states are using and who's engaged in a mental health crisis response. And again, we're finding some variability here. And the biggest issue here is that the states sometimes don't know how to use the peer supporters. We have practice guidelines from the National Association of Peer Supporters that says peer support is voluntary. Well, if you're in a hospital involuntarily, does that mean that you can't have peer support? Does that mean peer supports can't practice there? What does that mean? And so we also need to continue to provide clarity to the states about what is the scope of our practice, especially in crisis settings or when people are under involuntary holds and the like. All right, so here's some of our barriers. I'll just run to it. And I like hurdles instead of barriers because I used to be a hurdle runner, if you could imagine that. And hurdle running is very strategic. You just don't run and jump over the thing. You have to know kind of what is, you have to know your stride and all that kind of stuff. So one of the things where we're looking at more guidance is from CMS, particularly around age and prior education. So CMS says, actually, they're silent about age, but what happens is states interpret that the age must be 18 or above because CMS says that you have to have a high school diploma or equivalent. High school diploma, 18. So that's what happens. But they didn't say that, but that's where we go. Also, high school equivalent. The equivalency, people go to GED. You don't need a GED. It can be whatever the state says is the equivalent. So I think we need some clarity to the states from CMS about some of those criteria. Also, we need to think about career ladder. Some people come in and they don't move. And so what's the incentive to come in if you actually can't move up into some kind of career ladder? Supervision, again, CMS provides guidance around supervision, and that can be interpreted very linearly as far as a qualified behavioral health provider is what they say has to be the supervisor. So you could actually write that a peer supporter is a qualified behavioral health provider, so a peer supporter could be the supervisor. Right now, it's licensed professionals who know nothing about peer support, so they're turning out many clinicians and people are operating out of their scope of practice. If we want to achieve the outcomes that are on that page, which is reduced hospitalization, longer tenure in the community, having a better understanding of how to move forward in your recovery, if we want to achieve those outcomes, we have to be operating within that scope of practice. We have variable wages. It's all over the place. Rates are ridiculous all over the place, from the lowest around, I believe, let me see if I can find my notes. I'm not going to be able to find my notes quick enough. But the highest rate, I believe, was $24.36 per 15 minutes, and that was in Georgia. Of course, because they've been doing it, I think, since 2019, I believe. And then, I'm sorry, they've been doing it far longer than that. I don't remember the actual year. But the lowest rate was $7.83 per 15 minutes. That's a wide variability for billing on the very same code, which is a H.038 code in general. Okay, what is the other? Oh, and then we actually need more data, again, about the wage, who are they, where are they, what are they doing, and stratifying that information. We need to think about telehealth and technology. We've actually advanced in California digital health navigators, and those are peers. Part of our core competencies, we've added two to the national ones, which are digital literacy and cultural, not just cultural competency, but structural competency. So we also need a SOC code or a standard occupational code. We are under community health workers, again, which just confuses people. Community health workers and peers are a different profession and scope of practice. I know I'm running out of time, so I think that is, and there is a new bill I want folks to be aware of, which is the Providing Empathetic and Effective Recovery Peer Support Act. And the goal of this bill is to enhance the recognition of peer support professions, eliminate barriers, and do things like create that distinct standard occupational code, codifying the recovery office of SAMHSA, and researching hiring barriers and provide evidence-based solution to our hiring barriers. I'll just run through that. And then I provided these resources for you at the end, and I always like to end on, be good trouble, be necessary trouble. That's what we need in this profession. Thank you.
Thank you all very much for your comments and thoughts on the workforce development for mental health and wellness and addiction. We are going to have a very quick, albeit important, conversation about mental health and wellness workforce here. And I'd like to kick things off by asking a pretty general question. One thing I heard from all of you all is that it's an all hands on deck situation. We need everyone. And when we think about the different varieties of, the alphabet soup of doctors and LMFTs and therapists and peers and behavioral health support specialists, how do you all imagine creating a pipeline for those patients who are in treatment to actually navigate the different alphabet soup that we have, particularly when we think about scope of practice, when we think about who shows up when and where and how, and when we think about things like reimbursement and how might we be able to manage that from a policy perspective. Not that that's a lot, but
I can share one way we do this, and it's really a principle of ours, is to look at functions. Number one, you have to engage with the person, and then try to collaborate with them, talk with them, and look at kind of the resources we have, but what functions are needed. And then, as I had kind of outlined, who can perform those functions? So if it's psychiatric medication management, who can perform that? If it's psychotherapy, if it's peer support, or if it's health education, there may be some functions that are shared by a group of people. And then we have to look at who has the best connection with the patient, what can be reimbursed, et cetera. So for us, it's been very useful to focus on what functions are needed to help partner with this patient or consumer. And then let that guide who on the team can perform those functions.
Yeah, I guess I want to add a couple of thoughts. One is I love team-based care. This is what I do. I still think it's really important that someone does own that primary relationship with the patient. And I think there's a tension between task sharing, which, I'm a big fan of, and like that person feeling like they're just being passed from person to person. So I think there's a really important function of thinking about somebody really owning that primary relationship with the patient that we need to think about as we expand the workforce. And being intentional about that, I think, is important. I also have been thinking a lot about how do we educate our patients about who are all these different people they might encounter. And I've been thinking more and more around maybe some kind of matrix that has functions like this that we could put up in public spaces so patients could also be a bit more informed about who are the people that they're working with and what can they ask, what things can that person be helpful with. So I think those are really important things for us to think about as we expand that workforce, because I don't think it's straightforward, and it's hard to be strategic, and use everybody at the top of their license and not have 20 people, in that experience feeling very disjointed for the patient.
Now, I'll just add that, I worked at the LA County Department of Mental Health, which is the largest public mental health service provider in the country, and we had chiefs of each discipline. So I was chief of peers and allied health professions. We had a chief of psychiatry, a chief of psychology, a chief of nursing, social work, and psychiatry. And we were the office of the chiefs, which sounds really weird, but you know what I mean. Well, they said chiefs of disciplines, and that scared everybody. But the reality is that we also helped all 6,000 of our employees understand those functions and how to think about what is the role, what is the function, and then also explaining that to the peers. But we had to the people receiving services, but it was constant training too, because people would fall out of scope really easily, and then sometimes there would be this tension about, who gets to be that primary person. And so I was, thinking during that time about that therapeutic alliance, which Dr. Pincus, I believe, talked about. The importance of therapeutic alliance. Who has that strong alliance with the person? Don't break it because that person is supposed to be the person who's the lead. Right. It has to be the person whom they have that alliance with.
As we think about therapeutic alliance, I often think about, sort of the difference between treatment and wellness. And I really think about peers in that particular just sort of paradigm. And if we're thinking about how do we develop the workforce to move people from treatment to wellness, how do you think peers could be involved in that?
I mean, I think peers are critical. And, just from my own, personal experience, I actually didn't believe recovery was possible primarily because I did not see people who look like me, like up on stage talking or, giving presentations at even at peer conferences or recovery conferences. And so I thought, well, if we're not up on stage, but I see all of us Black people like in the audience, I have to wonder, is recovery really possible? So the minute I sort of brought that up, somebody introduced me to Miss Jackie McKinney, who lived all the way across country, who's a person who started the National Consumer Survivor People of Color Network. And when I met her, that's when I was like, oh, wow, I could do this and you did that, and how did you do that? And so it became a partnership. It's not an either or, but it's really about that partnership to help a person be able to better articulate what are their life goals and how do those life goals and recovery goals align also with their treatment goals. So it's this both and. So I have a hard time with like treatment and wellness. I mean, treatment should be about wellness and you know what I'm saying? So I think, again, helping to utilize that peer to do some of the translation. It's like we have a certain way of just talking in everyday parlance about sort of what's important to us that turns into a treatment goal, but we don't understand that it's a treatment goal. So how can you use the peer supporter to do translation back and forth between the person receiving services and the treatment team and the treatment team back to the person receiving services?
I think that ties in nicely to something Teresa Win was talking about earlier, was really when you find those peers, you're really finding the people who are next in line for becoming part of your long-term workforce, and I think that that's super important. I know that I'm looking through the audience. We've got a short time left. Is there any question from the audience? Up front.
You want to borrow this one? I guess 3 comments. It's been really impressive about how the sort of the peer support concept has been sort of systematized and so forth. What about the other categories of people?
Yeah.
Just thinking about the, behavioral health care managers or case managers, the other types of categories. Has there been any further evolution of the specification of these categories and of the functions, so to speak, an ontology of functions that's been more universally accepted? Number 2 is I'm familiar with the IAP program in the UK that you talked about. One of the concerns about that is that one of the good things about it is it's very much integrated into the overall National Health Service. And so they're linked to specific GPs. One of the which is a good thing, but one of the concerns about it is that it has resulted, from some perspectives, in de-skilling the GPs with regard to behavioral health, because they simply send people over to IAPT, and so that's it's sort of another issue, and so it comes back to the question: is there any kind of sort of universal standardization of these categories, sort of as has been done with peer support?
I mean, I know for community health workers and promotores, as those are also being advanced, I would say even more rapidly than peer support these days, that we're starting to see more standardization in those areas where at first community health workers said they didn't want that. So now there are some certifications and trainings for community health workers and promotores. For case managers, I am really not that familiar if it's as standardized and if the workforce actually wants to move in that direction. Yeah, so I don't, maybe you all are.
I guess I'll say that I do think having payment models has forced some definitions around that. For example, for the collaborative care codes, those are based off of the behavioral health care manager's minutes. So there's a list of things that they could actually do. And I mean, I don't think that that's perfect, but I do think it has been an example of, and Medicare purposely defined that pretty broadly, that it has to be somebody with behavioral health training and I think a bachelor's level degree for, at least for FQHCs and RHCs, it's complex. But I think that that's been helpful in that there was some room there to have a variety of people, if they can provide those tasks, actually be able to receive reimbursement for that, which is a step in the right direction. Do I think it would be helpful to have more definition? Probably. I mean, curriculum are wildly different across all of the training programs, and they're old. I mean, I'm just going to say they have not progressed, and I couldn't understand that for the longest time, and then I started talking to people, and it became really clear to me as soon as I talked to some of the programs that offer these degrees is that every time you change one of your classes, you have to go through the whole certification process to be able to offer that degree again, and so that's a huge limitation in people innovating or moving their curriculum to catch up with the way we're delivering care these days. And so it's really interesting to think about some of those tensions and how they're limiting us in being able to move our workforce forward.
So I think we are past being out of time. So thank you all for beginning this very important conversation. Thank you so much.
Tonight's
I know it.
Thank you. Hi. Thank you. Thank you to that incredible panel. That was wonderful. And thank you to Dr. Stewart for helping with that. So I think as we're getting ready to close the event, I want to welcome to the stage KP's Vice President for Mental Health and Wellness, Simon Borger, and we've asked him to provide some reflections on today's panels. So as you come up, I'll tell the audience a little bit about you, Simon. So he is the Vice President for Mental Health and Wellness at Kaiser Permanente. He's trained as a licensed psychiatric social worker and worked as a clinic-based therapist for Kaiser Permanente for more than 10 years before moving into a management position. In his current role, he leads the transformation of Kaiser Permanente's delivery of evidence-based, outcome-driven mental health and addiction care therapy and counseling services. Simon's known for his work leading the development and implementation of feedback-informed care for both Kaiser Permanente San Diego as well as more broadly. Simon has also been a strong supporter of collaborative care and leveraging Kaiser Permanente's integrated model to best meet the mental health and wellness needs of its members. He has successfully moved forward a plan to bring interventional psychiatry to Kaiser Permanente in San Diego as well. So thank you, Simon. Here you go. Thanks.
Thank you. My pleasure to be here today. I am the Vice President of Mental Health, Wellness, and Addiction Care at Kaiser Permanente, but I think of myself as a social worker, and it was just an honor to be in this room with all of you and to be talking about how we can collectively work together to improve mental health care in this country. I want to thank our esteemed panelists for their time, their energy, their expertise, and their engagement today. You were really the stars of the show, and I think you helped make today's forum a success. As we heard from them today, we are really at a critical juncture. We desperately need a diverse and expanded workforce to provide high quality, effective, and equitable care across this country. Our panelists shared how with the correct data, we can measure the effectiveness of that care and drive improvements in care delivery. They also explained how we can drive for better access and quality through an expanded and diverse workforce. We learned today about what KP is doing to improve quality in a variety of ways. That includes our integrated model, our focus on outcomes measurement. I was very glad to hear the concept of therapeutic alliance called out a couple of times today, because that's really a cornerstone of our care throughout the ecosystem of care that we provide for behavioral health. But we're also working to bolster the mental health workforce through our Mental Health Scholars Academy, our Mental Health Accelerator programs, building associate programs in our markets, and also the Behavioral Health Training Institute. There's a lot of work ahead of us in this space, and we are thankful that we have you walking shoulder to shoulder with us on this journey. I'd like to build on the energy from today and really think about how we can collectively support policy that moves the country towards licensed reciprocity for mental health providers. We really need our social workers, our marriage and family therapists, our licensed professional counselors, and our psychologists working across state lines. I think we can take that energy a step further and look to champion policy that supports the growth of a diverse cadre of peer support specialists, paraprofessionals, and behavioral health support specialists that we learned about today. These providers can play a crucial role in providing increased engagement and outcomes for mental health and substance use disorder care, while also helping to diversify our clinics and the communities we serve. The discussion today really leaves me hopeful. The focus on equitable care, diversity in the workforce, and quality outcomes gives me a sense of radical hope, which we heard about this morning. So again, I want to thank you all for being here and for your engagement. It was a wonderful day. And Cecilia, I'll turn it back over to you to close the program.
So I am going to add my thank you to our speakers and moderators. And I would just like to take a few minutes to also thank our caterers, Ridgewell's, Spark Street Digital, our partners for many years in producing these events. Photography today was by Kian McKellar. Thank you, Kian. And thank you to, there were many others that helped support the development of this event. We have an internal working group and a steering committee that help inform the topics that we choose, and so we'd like to thank them. And importantly, the Institute for Health Policy staff, especially Renee and Rebecca, that really pulled together today's event, Kristen, Ben, and Nani for helping with all the other details as well. We have Marilyn Darciaga and Wendy McAllister that also really played invaluable roles, and for our hosts at the Center for Total Health. And most of all, I want to thank all of you for coming and attending today. But before you leave, we'd like you to take a few minutes to fill out the end of this event survey. We really do use the information that you send us. It helps us sort of think about new topics to cover, including today's. And then if you have been on social media or are so inclined, again, use the hashtag KPIHP to reference this event. So with that, I want to thank you all for coming and joining us today, and safe travels back, and have a good weekend. Thank you.